All right, guys, welcome. We are so excited to have you all here at our 2002 Bonheur Diabetes School Care Plan webinar conference. It's going to look a little different this year, but we're really excited for everyone who has registered. I know we're still waiting on one school district that's having a little bit of trouble getting in, but we're going to try to keep on moving just so that we can get all of this great information in. Today, let me see. Will you click on the slides? I have some friends helping me today, thankfully. So our agenda today, I will be presenting with Miss Anna, one of our other diabetes educators, just an overview and introduction. We're also going to have representatives from two of our insulin pump brands, Tandem and Omnipod, come and present about their products. And as well, we'll have some continuous glucose monitor brands, Dexcom and Freestyle Libre, who will discuss their products. And then we will have a representative from Medtronic to talk about their suite of products, as well as Gvoke. And then we'll wrap up the presentation at the end with our Bonheur team. We're going to kind of talk about diabetes technology and school care plans. If you have any questions, we will not be using the chat feature for this webinar. At the end of everything, you will have access to all of the emails for all of the different reps. So if you have a question for a specific presenter, for example, Ms. Tamil is going to present first on Tandem. If you have a question for her, you'll need to reach out directly to her just to get that best answer for that. So you'll have that at the end. If you have a question for our Bonheur education team, then you can use the question and answer section. Questions will be answered at the conclusion of the presentation if we have enough time. If not, what we'll do is we'll take all those questions, we'll answer them, and we'll email them back out to everyone. So if you have someone who is attending in a group setting right now, because I know some of the schools have auditoriums, make sure you get every single person registered just so that we can make sure that any emails that we blast out after this, everyone gets that data. All right, and then if you are new to being a school nurse or just need a diabetes refresher, because I know not everyone has a diabetes kiddo every single year, we do have some skills sessions that we presented on last year that are on YouTube. And so these are the links to those. I also emailed them out yesterday to anyone who was registered by yesterday. So you can go and review those. Or if you have a diabetes kiddo that's diagnosed in the future, these will be on YouTube so you can access those. And now I'm going to hand it over to one of our diabetes technology experts, Miss Anna Heston.
Good morning, everyone. Again, my name is Anna. I am one of the diabetes educators at Bonheur. So I know, as Erica has talked about, kind of the two focuses is insulin pumps as well as CGM. So just a brief overview, if you've not had any experience in your schools regarding these. So insulin pumps, just a general overview, is typically an electronic device that delivers insulin from the cartridge into a tubing to a cannula that's inserted in the fat of the body. So we will have presenters and they'll probably maybe show their device so you'll kind of get a better picture of what it looks like. And then there is a tubeless pump called Omnipod, and they're pods that are on the arm. And so the cartridge is located in that pod. So insulin is delivered in two ways, through basal and bolus, and I'll kind of get into that in a second. Then there's continuous glucose monitoring. This is something that you'll probably see maybe a little bit more of, and it measures the interstitial fluid, the glucose in that interstitial fluid. It does measure in increments of 5 minutes your blood sugar, so it kind of shows a graph, as well as some benefits. It kind of tracks trends of high or low blood sugars, and it can alarm you for quick changes in those blood sugars. So with these two technologies, devices, they are great. They can be used separately, but they really do complement each other as well. And you'll kind of see that later through the other presenters. I'm clicking on the screen. There you go. All right. So for insulin pumps, a lot of times with our kiddos that are on injections, they're on a long acting as well as a rapid acting. The long acting is kind of like a 24-hour medication given once a day typically, and then the rapid acting. You can see kind of the list. So like Humalog, Novolog, those are two common brands. In a pump, the only thing used is the rapid acting. So they would stop the long acting once they're on the insulin pump. If it comes to where they have a pump failure, they can't get back on the pump, then we would need action of starting back that long acting insulin if they're going to be off their pump for a long time. So if their pump comes off or it stops working, we need to kind of call the family, have some type of plan as to what happens if their pump does fail. And then going back, so I know I was kind of talking about we're just on rapid acting insulin for these insulin pumps. So there's kind of two different types of settings in these pumps. So kind of what we were talking about, that long acting insulin. So we stop that, and it's kind of a 24-hour medication. It gives you a little dose every hour. Since we stopped that, the pump has what's called a basal rate, and it delivers a small amount of insulin continuously. So it replaces that long acting insulin, it gives it in small increments, and it's adjustable by time periods. So that's why we stopped that long acting, and we can just use the rapid acting for that. And then there's bolus rates, and that's the delivery of insulin doses on demand to cover carbohydrates eaten as well as correction of blood sugar. So the patient or the school nurse would still have to input the carb amount and blood sugar to deliver that bolus for their meal. And just kind of managing some expectations regarding the insulin pump. This is kind of a cool, some like unrealistic, first realistic, expectation. So a lot of the times, like, people get really excited about the pump, and I like to think of it as the pump can decrease your thought burden. It does kind of relieve sometimes some stress, but it won't cure your diabetes. It will make you feel better just because of some of the technological advances. It can kind of help keep your blood sugars more in range. Another kind of unrealistic expectation, I won't have to test as much. A lot of times people on pumps are still using that CGM, and we're still having to monitor as much as we would just on finger sticks and injections. I can eat anything I want. There's still some things we want to set boundaries on, but you will have a lot more freedom with food choices. And then my blood sugar will be perfect. We will probably have a better control with fewer lows with the insulin pump. As well, it will be easy to learn as a meter. The pump does take a little bit more of a learning curve. If they do start on a pump, they will meet with a pump rep and have a few hours of education to initiate it. So it is a little bit more intricate than a meter. And that's it for just the general overview of what an insulin pump is and kind of a little bit of a CGM. So I'm going to hand it over to Tamala. She is with Tandem Insulin Pumps, and she will kind of talk about that.
Good morning, everyone. Technology is always fun.
I might just have to read them for you.
Okay.
I think it converted it to PDF.
So good morning, I'm Tamala Jones. I'm a nurse practitioner and a CDE with Tandem Diabetes Care. And I'm excited and feel privileged to be able to speak with everyone about pump features of our pump called the Tandem T-Slim. So we're going to go through some slides. I may buzz through a couple of them since they did a nice little presentation already, and it did on basal bolus. And yes, please, Erica will share my contact information with everyone. Please feel free to text, call, carrier pigeon, email, however you need to get a hold of me. And with any specific questions about your kiddos or about pump therapy or specifically about the T-Slim. Let's see if we can get these slides rolling. Okay, so just a quick overview of kind of a general role or general responsibilities for school nurse. And I'm sure this is review for most of you, but having a firm understanding of just the diabetes process, insulin pump therapy and doses, when you need to seek more advanced medical attention, troubleshooting, identifying hypo and hyper, and what's considered normal glucose levels. You may also assist with delivering bolus, counting carbs, giving glucagon. I am not going to review temporary basal rate just because of the algorithm of the way our pump is set up. So if you do have specific questions about temporary basal rate, please reach out to me. So quickly, just looking at hyperglycemia or high blood glucose. This is common causes can be due to stress or illness, increased or decreased activity, underestimating of carbohydrates, so not enough bolus was given for previous meal. Symptoms include nausea, thirst, that fruity smell to the breath, frequent urination, and fatigue. For hypoglycemia, so this would be low blood glucose. For some reason, there's too much insulin and not enough glucose. Common causes of this can be increased or unexpected activity, overestimation of carbs. So the kid received too much insulin. Symptoms can be shakiness, be sweaty, irritable, drowsy, inability to concentrate, and anxiety. The symptoms can overlap between hypo and hyper, which of course makes diabetes even more difficult to trying to determine what's going on just based on symptoms. Treatment for hypoglycemia, which is more of an urgent issue. If it's mild, your kiddos have been taught how to self-treat with a fast-acting carbohydrate, but may need assistance or reminders of this. Severe, if they are unable to respond, they will need to be treated with glucagon or IV glucose, which would be needing to call 911 or using whatever their glucagon is that they have personally for them. So basal bolus, Anna's already covered, so I'm going to skip through all of this. There are two different boluses. Usually the food bolus, carb bolus, meal bolus is taken with meal or snack. Correction bolus is when extra insulin is given in a shot form when the patient's on injections, but through a pump, it's given through the pump using the bolus feature. And we are going to go over that, because I suspect this is going to be the biggest part of your assistance with your kiddos with diabetes. So with food bolus is calculated using grams of carbohydrates in the meal and their carb ratio. And I know y'all do a good job of having the carbs already pre-printed for parents, weeks or a week or days in advance, so that this can be calculated for each day. And then the carb ratio is written within their plan, or it is also already pre-programmed into the pump. The correction bolus uses their current blood sugar, their current correction factor, their target, and insulin on board. So insulin on board is the amount of insulin they still have working actively to bring down their blood sugar. And this is all calculated within the pump. So you don't have to do this math, thank goodness. It is all done for you. And their target can change, but this is the goal. This is what we want their blood sugar to correct to anytime we're giving a bolus. So insulin duration is what gets, it's kind of the definition of insulin on board, is how long that insulin is working, like we talked about just a minute ago, to bring down that blood sugar. And this is all tracked in the tandem pump with the term of insulin on board, and you can see it on the front of the pump, how much insulin is still actively working. So that number is calculated into the bolus to prevent stacking or to prevent overdosing based on how much insulin is still present. Future doses are decreased or adjusted to help prevent too much insulin or those hypoglycemic episodes. So the infusion set system, this is what the tandem pump looks like. The insulin is pushed into a cartridge in the pump using a syringe. Then it's connected from the pump to tubing and then connected to the cannula, which is a tiny little filament, little somewhat flexible cannula that is kept under the skin. The nice thing about this is it can be disconnected. You just squeeze the little prongs and the kiddo is off their pump if they want to swim, or if there's issues, they can just connect and disconnect very easily. So troubleshooting for hyperglycemia on the tandem pump, when you get either too high or too low, here we're looking at too high, the children get an alert that tells them you're above goal and a bolus is suggested. So some things that can cause hyper are the things you would look at are in there are issues with infusion set, issues with the insulin or the pump itself, or behaviors. So if the different things you can kind of troubleshoot or double check is the infusion set cramped, pulled out? Does there appear to be air in the tubing? Is there a loose connection, or is there bleeding, wetness, swelling at the site? These are all things that would be interrupting the infusion of insulin as related to the infusion set. What to check as far as the insulin or the pump: was the insulin expired? Was the insulin exposed to heat or cold? And I know we are all seeing this right now since we're living on the surface of the sun here in Memphis. When it's 108 heat index, kiddos have this pump against their bodies, so they're getting insulin heated through body heat and temperatures outside that can degrade or decrease the effectiveness of their insulin. Also, they need to have battery charge. There may be a programming error. They may be out of insulin, so an empty cartridge. It may be that they just need a review and adjustment of their settings, and then the pump will alarm for many of these. What also to check for behavior. Sometimes, we have user error that we have to address. So maybe a food bolus was missed. Maybe they have not bolused. Maybe they did not get enough for a high, or just things in, life happens, as we say. So what to do? You always have the option to take an injection with a pen. So we say, treat the patient, not the pump. So when in doubt, change it out is one of our little mottos. So treat your kiddo. Don't worry about what the pump is doing. You can pull off that infusion set. They are now off the pump, and you can treat with an injection. Here's our customer support number. I'll make sure to get that to you if we need it also. To unlock the tandem screen, you hit 1, 2, 3, and you can get into any of the screens. The thing that you'll be looking at the most is bolus. So you would tap bolus. I'm going to kind of cruise through these slides, but you tap grams. It's so easy. You enter the grams by putting in 45 or check. The glucose will already be pre-populated for the patients that are connected to either basal IQ or control IQ. And you hit check, the T-Slim does the math for you, and that bolus is given. Here's the drop. To cancel, you immediately get the option to cancel the bolus if needed. So you have to hit 3 checks to give it. You can automatically or manually cancel it immediately. So it's pretty quick to bolus, but you don't have to worry about getting in over your head, so to speak, because you always have the option to cancel. So Control IQ technology is the algorithm that the T-Slim uses. It works in conjunction with the CGM, with the Dexcom, and can make adjustments every 5 minutes. And we're looking 30 minutes ahead. So we are working to prevent lows and prevent highs as predicted by Dexcom values. So the CGM updates the pump or updates Control IQ every 5 minutes. We watch trends. We take into account, we meaning me and the T-Slim, we take into account past insulin on board, and all of this is used to continue adjusting. Basal rates can be adjusted every 5 minutes, and an automatic bolus can be given once an hour. So things unique to Control IQ were changing, just with all the technology we have, we're changing the way we do diabetes. You know, back in the day, it was, oh no, my blood sugar's 240, I need to fix it. Now it's, oh, we're not going to get there. We're going to work on that before we even get to that high. So protecting from highs and lows, the automatic correction bolus gives 60% of the calculated bolus every hour for added control. And this system not only, as I've said, adjusts basal, but also gives us bolus once an hour. So it's very aggressive as far as getting that blood sugar down, but also things are put in place, safety nets, to prevent lows. So that's why the bolus is 60% rather than the full 100%, because basal rates adjustments have already been undergone also. So our studies have been just beautiful, showing that A1Cs have dropped dramatically, time in range has increased, and without all these lows that, of course, are super scary for everyone. The Dexcom numbers do pre-populate so that you don't have that possible issue of entering an incorrect blood sugar. It's right there. So you enter your carbs, the blood sugar is already there. You hit check, 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 and you can just give it a bolus. Also, something fabulous about the Dexcom is it does not require calibration. So the patient goes from maybe finger sticking 6 to 8 times a day, from giving insulin doses 3, 4, 5, 6 times a day, to now they do one site change every 3 days. And if everything's copacetic with the CGM, as it is most of the time, then they're not having to do finger sticks. Not routinely like they were. So pretty awesome. Something else we have with Control IQ is sleep activity. So we use all the biometrics from overnights of how your temperature, your blood pressure, your heart rate, everything settles out nicely overnight. So we take advantage of that to get their blood sugar nice and tight all night long, to keep it between 110 and 120 so that they sleep good. They wake up feeling great, and the whole family sleeps. This feature is the thing that has touched my heart the most. I've had mamas come into me and say, our whole family has slept for the first time since diagnosis, because we know kiddo is safe. We're not getting woke up with highs and lows and alarms all night long. And the day starts out beautiful because you wake up with a normal blood sugar. Exercise activity, when we have our diabetes camps during the summer, this exercise activity has been huge. It allows the blood sugar trends to rise higher. So we say we kind of let them float up higher to prevent those lows. So taking into account that they are going to be more prone to drops to low blood sugars because of exercise, so to prevent that from happening. So we're not having kids that we have to pull out of the pool because they're too low, because we've let their blood sugar rise a little higher in anticipation of that exercise. And there is nothing complicated. There's no criteria, no learning period. You hook them up and they are on Control IQ, and it learns them, yes, but immediately the algorithm starts. So there is no calibrating. There's nothing that needs to be done to initiate or continue the system. So anytime the changes that Control IQ is making are visible on the pump. We also have a T-Connect app, which will be on the child's phone, and you can see what's going on. So maintains is where we want to keep them. So that's keeping them between a blood sugar of 112.5 and 160. If they are out of that range, like a dimmer switch, Control IQ either increases or decreases their basal rate. So remember blue, like the high blue sky. If you see blue on the front of the pump on the little Control IQ diamond, you'll know that their trends are increasing and they're getting more basal rate. If you see the blue box with the white droplet, you know they received that once an hour auto bolus. If they're going low, so yellow for caution, that would be if they're predicted to be less than 112.5 in 30 minutes, then Control IQ decreases their basal rate. If they're predicted to be less than 70 in 30 minutes, it stops their basal rate. Everything on the pump lights up red. But the pump is not off forever and ever, amen. It is off for 5 minutes, 10 minutes, 15 minutes until they have had their carbs and they're on the rise again. It automatically turns them back on. So when they get to the red, to the 70, and the pump is turned off, they get an alert that says you need to eat 10 to 12 grams of carbs. So this is when you would give that quick acting. They need pure sugar. They need juice or real Coke or Skittles or whatever is in their plan to use for their low. And then once the pump turns them back on automatically when they are rising and in a safe level again, then they need to eat. They need to have something with protein and fat, peanut butter crackers or something quick and easy to keep around. If they're going to be high, they do get an alert at 200 that states you need to troubleshoot. You need to look at cartridge, tubing, pump, where they predicted to be high, even though they've had increase in basal rate and had this auto bolus once an hour. So the pump does alert you when it's time to intervene. And as I said, you will see on the front of the pump or on the app, the different colors that will change to let you know something's going on. Exercise activity I touched on already. This is 2 clicks to put them into exercise activity and to allow their blood sugar trends to rise so that we're not having to snack them or have them drop while they're playing. This is something I think would be super helpful to nurses out on the playground or during PE. So please feel free to reach out to me if this is something we need to go over a little more in depth as to when you would initiate exercise activity and how long you would leave it on. That's how it's customized, is the length of time that it's used. So the automatic correction boluses do not eliminate the need for manual meal bolus. So remember, I did mention that they get 60% of what's predicted or what it would be recommended because they're already getting basal rate increases also. So I tell parents and tell kids, you can tap that bolus button anytime. And if it is recommended that you give, 1.2 units, whatever's recommended, it is safe to give that. Now, our goal with pumping is that you're living life for you, not living life for your pump and not having your diabetes control you. So I sure don't expect anyone to be tapping on their pump all day long to see if it's time to get more bolus. But you do have that option. So if you're predicted to be above 180, like we mentioned, you are given an increased bolus, the kid is given an auto bolus, but you do have the option, the child, the teacher, the parent, at any time to tap and see if additional bolus is safe, and that will correct that high faster and still safe. So the alerts that you get, we mentioned this one already, but it's an important one, so I wanted to cover it twice. A hypo gets you into trouble quick and you feel awful. So we want to address this super early in the process. So when they get an alert that they're less than 70, they need to stop, drop, and roll. We need 10 to 12 grams of quick acting carbs immediately. We've always taught in the past the rule of 15, which is you eat 15 grams, check 15 minutes, eat another 15 grams, check in 15 minutes when you're below 70. With Control IQ, that's judged a little bit because they may actually be at 85 right now. they're predicted to be less than 70 in 30 minutes. So that's why we can back off on that correction a little. And also, we've already been working on that low for quite some time by decreasing their basal rate ahead of time. So when they do get the alert at 70, their basal rate has been turned off and they need to eat 10 to 12 grams of carbs. The parents are taught this, the kiddos are taught this, so that everyone knows what 10 to 12 grams of carbs looks like. If they're using a juice box, if they're using Skittles, if they're using glucose tablets, exactly what that correction is, how much to eat or drink. As mentioned, they also get this alert at 200. So why are they high? Did they miss a bolus? Is it all those other things that we talked about? Is it an issue mechanically? Have they pulled out their sets? Is their insulin hot so it is degraded? What exactly is going on with that 200? And you can see it says, check your cartridge tubing inside, test your blood sugar, see what is going on. Another alert would be the out of range alert. So the Dexcom sensor and the pump have to be within 20 feet of each other to speak or to communicate and to make adjustments. Usually this happens when the pump is taken off for the kiddo to bathe, and now they're running around the house with their sensor on, but the pump is still in the bathroom. You get this alert. I could see where this might happen if they take the alert off or take the pump off for some reason. To swim usually is when we see it, but if you get this out of range alert, you just need to make sure that the pump and the sensor are everybody's back in the same sandbox again. Nothing has to be done automatically. They will reconnect and Control-IQ will start adjusting again. So lunch bolusing tips specifically for you school nurses. A lot of students bolus after a meal. We really suggest that they get that bolus in before, if at all possible, 15 minutes before the meal or right when they start eating the meal. The reason we ask that they not bolus afterwards is Control-IQ is going to start responding immediately to a high. So they will be getting increased basal rate. If they're going to be above 180, they will also get a bolus with that high. If you've not put in that bolus before as a carb bolus, the pump doesn't know that it's a meal. It just knows they're going high and starts reacting to that. Then if someone gives the bolus after the meal, you're basically double bolusing for the same thing. Because Control-IQ is so fast, it's already reacted to that high. So if you bolus then afterwards, now you're bolusing for a blood sugar that's already been addressed. So again, this is something I'd love to talk about depending on what your protocol is. I know it's probably different for each kiddo, but just to make sure we keep kids safe. A lot of times we will have them bolus for maybe half the meal before, and then when you see what they actually do consume during the meal, then you could give the rest. So there's a lot of options to work around this, but just keep in mind, bolusing too far after the meal is going to get you into a situation with lows. So here's all of our disclaimers. So I left a few minutes for questions, which we don't really have, so that you can get those. Oh, Erica has a question.
So, you know, I pulled one of these demos so you can show what the actual, for those of you who haven't seen a tandem pump, this is what it looks like. It's a little black box. It has a touch screen on it, which is pretty cool. And really a perk for a lot of our teenagers, especially that like to do the touch screen. So when she's talking about the alerts coming up, they're on the pump screen right here. Now, Tamala, tell me about the new app that launched though.
Yes,
So
since we have time.
yes, because, you know, for schools, especially those pieces of technology, the phones are a big deal. So like what is the responsibility of the phone and what kind of goes there? And can you tell us?
Awesome. Yes, thank you for asking. So it just launched general, so everyone is getting an alert today. It started last week after doing a limited launch that you can do that bolusing piece from the phone app. So it is a software update. The kids' parents can go into their T-Connect account through Tandem. They have training they have to do. They have a test they have to pass to be able to download the new software. It's called Mobile Bolus. And what it allows you to do is everything I showed through those previous slides of entering the carbs, seeing what the blood sugar is, hitting your check to deliver the bolus. That is all done through Bluetooth straight to the pump.
Okay.
So it will be only on one pump or one app, one phone. So your older kids, that is something, great question, that will need to be addressed is phone access, because they will need that access to their phone to be able to bolus from the app. Obviously, we don't put the app on multiple phones because you wouldn't want everyone running around bolusing. So there's education that goes along with that. They have to have already had training on the pump, and then that upgrade can be done. As new pumps are coming out later this month, they will already be updated. The apps will already be updated. So it's going to be a flurry of excitement and things going on. But yes, we've already seen it. All the employees at Tandem that wear the pump that have diabetes have already been using the bolus, and timing range has increased just because it's so easy. It's right there. And as you can imagine with your kids, they're not having to pull that pump out to bolus. So it looks like they're texting on their phone, and no one has to know they have a pump in their bra. So they're not having to, dig under the dress to get it. So,
and that does the alerts to the phone as well, like the high and low alerts. And then is it the same app that you'll be able to see the CGM data? So that Dexcom data, so children shouldn't have to move from app to app. It should all be in the same app. So that's a good point to know.
Very good. Yes.
Okay.
Yes.
All right.
All right.
Sure.
Show it closer.
This is what it looks like. I know it's glowing. But this is kind of what it looks like. It does have tubing. And then one thing Tamela didn't talk about was pump site. So you talked about like the bra, but where else would probably a patient be putting a pump site with their tubing?
So the actual infusion set can go abdomen, hips, buttocks. For our little bitties, we usually will put it in the back so you can hide it under their diaper. It can also go in legs, and it can go in arms. The pump itself can be worn in the bra. In the South, we put everything in a bra. We got pacifiers, you can make change in there, So if you've got room, you can put it in the bra, but it also goes in a pocket or on the pants, or I've had patients wear it in their leg and run the tubing down their pants and keep the pump in a boot. So, I mean, there's lots of options of where you can hide it. So very good question. Great. Yeah. Clip it. So
it's a badge of honor.
It is.
It is. Yes. Okay. I don't see any
Awesome.
other questions. Anything else? I think we got 2 minutes left if anybody's got any questions. If not, then we'll take a short break, and then we'll bring in our next presenter.
Thank you. Thanks, Erica.
Thank
Thank
you so
y'all
much,
so much. Please holler if you have questions. Have a great day.
All right. Thanks, guys. We are going to pause momentarily, and then we're going to get our next presenter, Ms. Leah Hubbard with Omnipod. She is on deck next.
Hey guys, I'm Leah. I'm here on behalf of Omnipod, and I'm just going to go over the different models of Omnipods that you may see with your kiddos and give you guys the points and tips on how to use them. So our kind of original Omnipod version looks like this, and this is what you would see with the child. The pod that the child is wearing, no matter what version of pump they have, is going to look like this, okay? So this is what you would see on them. And this can be worn anywhere they would give an injection. So I'll show you guys this site sheet. And then this shows you the directions it would be pointing. And some people have a little bit more diagonal angle to it, but this is the recommended angles. So if there was some type of pod change that needed to occur at school. So this shows you the sites, okay? So if they're using this version of the pump, everything is push button on the screen. This is not a touch screen version. When you turn it on, it's going to show you that insulin on board, so you know if they have a lot of insulin currently in the body that you would need to think about if they were going to take a bolus or not. And to give a bolus, it's very simple. You're just pushing, whoops, time's out on me. Sorry. Hard to do it backwards. Okay, so you're just pushing the home, and then the first thing is bolus. And you're just pushing select. And then at this point, you would enter their blood sugar. So this could come if they're wearing, so this version does not talk to a CGM. It's just it's an insulin delivery device. So you're entering the blood sugar number from a finger stick or their sensor and just using the arrows to do that. And then it asks you on there, and it says, trying to make it get clear for you guys. Use for a bolus calculation, yes. And then are they going to eat? So yes. Enter the grams of carbs they're going to eat, enter, and then make sure that everything's correct. You're going to confirm it, and it would tell you the dose, and then you just would push enter, and then confirm. So you've got a couple things to confirm it. It's going to beep, and then the pod is going to start delivering that dose to the patient. So as soon as it starts, they can walk away from the controller. The controller does not have to be next to them while they're getting the dose. It doesn't have to be next to them to get their basal rate. So depending on how things are set up, whether they're leaving this with the school nurse, I've had a few kids do that, it's not as common, or if this is with the child. But as far as a distance or anything like that, the pod will give the patient their basal rate. It will change basal rates, anything that's set into it and programmed, no matter where this is located. Now, we don't want them to leave this at home because then they can't bolus for their meals. So, and when they start the bolus, it does need to be within 5 feet. You can't do this from across the room or anything like that. It needs to be within 5 feet to give the command to the pod, okay? So they're wearing the pod for up to 80 hours. So typically they're changing it every 3 days. We usually have them on a 72 hour. That's what the controller is going to tell them. They need to change it every 72 hours. But for instance, if they were at school and it got taken off or something like that, and they're changing it at a different time, then we would usually recommend they would get back on schedule and be changing it, of course, when they're at home, not while they're at school. Some things to check. So if they were concerned if their blood sugars are going up, you've got some visuals you can look at on the body. So there is actually a window here on the front of the pod, right here, that you can look into, and you would be able to see this cannula. It's really tiny. You guys can see the cannula on there. But so you could see that the cannula was under the skin, or if it had come dislodged, okay, and come out. Always tell people they can kind of give it the smell test. You can smell insulin. So if you sniff right here and you smell insulin, then it's probably not, or then it would not be going into the skin. So the window, if it looks red, irritated, something like that, where they would need to change if their blood sugars are going up. If their blood sugars are looking good, then they're obviously getting the insulin. So those are just some visuals that you could use with the pod. And again, this is the original version that a patient may be on. The second version,
And Leah, is just, that's the arrows. Is that
yes,
kind of
arrows,
original?
original arrows is
Okay, cool.
the terminology on this one. Yep. And this one does have a built-in meter, but I don't, do you guys
People
have any
really don't
patients?
use that.
I feel like so many people are on sensors now that no one's really using that, but it does if you needed a backup or something like that. There is a sensor built in here. So that is arrows for the original. The second version is going to be dashed. And so with this one, it's very similar to a cell phone. And I was actually going to show you guys the process for changing a pod with this one. So you can see on here, it says no active pod. Didn't want to pick it up. Okay, so it says it would tell them that there was no active pod. The pod change process, I'm just going to show you guys because it's so quick and easy. So pods look like this. So the patient's supplies are all here, and then they would have their vial of insulin. So they simply open this up. They put together the needle and the syringe. They just twist this on. There's a minimum line on this syringe. There's a minimum of insulin that they would have to fill it with. And then the max is 200 units. So they're going to fill it with what they need for the 3 days time.
And the families should know what they typically
Yes,
fill
yes,
it
the
with.
families would know. Yes, for sure. And I mean, I'm sure you guys, I mean, there's young kids that do this themselves.
Mhm.
So if you guys are just kind of supervising, watching what they're doing. So there's one place to fill with insulin. It's got a little arrow that points to the circle. And you're going to leave this needle cap on. It's really important they don't take this off yet. So you just push this in, fill it with their insulin. And I don't know if y'all could hear it, but it beeps twice to let you know that everything's good. So on the controller, I'm just saying, set up a new pod, and it actually gives you a visual of what the camera doesn't like it. There it goes. So there it goes. So it shows you exactly what to do. So it gives you the visual to follow the directions, which is great. So now it's going to connect. So I just have these sitting on the table next to each other. So all the settings that are in the controller are being stored over onto the pod. So the pod knows what time it is, what basal rate to give them each hour of the day, and it will automatically change. So this second version works very similar to the arrows. The pods look exactly the same. It's just a little sleeker controller. Some of the software things are different as far as downloading it. The download reports, but that wouldn't be anything you guys would see. So as far as controls, distance between the device, all that stuff stays the same because the pod is the same, and the pod is really the brains. The pod is where everything's happening. So that pod being waterproof, continual wear, you don't have to worry about them unplugging it, plugging it back in. If they are going low, you can definitely suspend any of the versions and turn off that basal rate. I've got a quick guide I was going to show you. This, which you guys you'll get a PDF of this, how to set that temp basal. So it shows you exactly what to go through. And so we've got access for you guys to have this if it's something you want.
I love those handouts.
Yes,
They're
this
really
is great. It shows you on one how to change the pod, exactly what to do, how to view and their history to see what they've been doing, how to give a bolus, and then that temp basal that I was just talking about, like if they were kind of running low or going to do an activity and you needed to help them set that. So after they've got the pod on, so at this point they would take off, or I'm sorry, after they've got the pod filled, they would take off the needle cap. Then they're going to just remove these adhesive backings and stick it on. So wherever they're going to wear it, so they just stick it on. And then it's completely hands-free insertion, which is great, especially for the little ones. So we're going to just push start on the controller. And then I don't know that this is going to pick it up, but if you guys watch really close, you'll get to see it insert. So if this was against their skin, and then there it goes. And then it goes ahead and it does fill this for them. So you don't have another step to remember to prime that. You do have a visual on the back of the pod where this pink, and again, I don't know if the camera's getting, so the pink goes into this little square. It's like a pink slide, and that just shows you that it's inserted. And they have that on there because some patients would say, I didn't even feel anything. I don't know if it inserted or not. So that just gives you a visual to know, yes, the needle did deploy and it's in. So now it's running. It's going to tell them when it's going to expire on this screen so they know exactly when it's going to expire. And it's also going to show them on here how much insulin they have in the pod left to work once they get below 50 units. So if they have greater than 50 units, the screen is going to say you have greater than 50 units. But when they get down below 50, it's going to count down 49, 48. So they'll know exactly what they have. So hopefully parents are not sending kids off to school about to run out of insulin. When they get to, it's going to beep at them when they get low. That's a preset option that they can pick where it's going to beep, if it's at 10 units or 20 units when they want to have that. But again, it's also going to show them on here how much insulin they have. So if someone's coming to school and they don't have enough insulin to last for their whole day, that would be where you guys might encounter having to help them change out their pod. But hopefully parents are on top and they're making sure that they change before school or in a rotation when they're not going to run out during the day like that. And then the last version of the Omnipod, our newest version, is Omnipod 5. And so it is actually run through an app. So patients do get a controller that looks very similar to this one. It's a little bit longer than this one, or they can run it on a compatible smartphone. And this app is probably not going to show for you guys, but the great thing about this, so this one is integrated with the Dexcom. So the other two versions are only giving insulin. It's not doing anything based off of blood sugar unless the patient tells the controller what the blood sugar is. With this version, they're going to see their Dexcom data on the screen, and they're going to see what their blood sugar is doing, see what the trend is, as well as, of course, their bolus information. So they can just push this little graph, and it's going to show, oops, turn it this way. It's going to show you very similar to how a Dexcom, the Dexcom app looks, okay? So the way this works is that the pod that they're wearing on their body is actually talking to the Dexcom. The Dexcom is sending the pod the blood sugar reading every 5 minutes, and then the pod is automatically adjusting the basal rate based off of what the blood sugar is, so going up or down. So it's amazing technology. People are loving it, but the patient is wearing both devices, and the two devices are just talking to each other and making adjustments. Now, the patient still needs to bolus when they eat, because the blood sugar and pump, if we waited for the blood sugar to respond to what they ate, now we're just chasing a blood sugar or chasing everything all day. So on their app, they are going to still need to bolus, which is very similar to what I showed you on here. If it showed it, how to deliver the bolus. The directions on this one, which are for the Dash model, it's very similar to how this app looks. So we click the picture of the bolus, or I'm sorry, the vial of insulin. And then you guys can't see this very well, but it asks for the carbs. So they're going to enter their grams of carbs, however many carbs they're eating. So let's say they're having 52. And then for glucose, you want to make sure that they're pushing the use CGM button. You don't want to look at the Dexcom and enter it. You want to push the use CGM. And that's really important because when you use the CGM value, it takes into account the trend of the blood sugar. If you just enter whatever their blood sugar is from their Dexcom at the moment, it's not going to take into account the direction that the blood sugar is moving. So you just want to make sure you push the use CGM, and then it's going to just bring over the blood sugar from the Dexcom at that point. Okay. And so then the bolus could be a little bit different if you sat down and did the math for the carbs and the blood sugar, because the bolus is taking into account the direction of the blood sugar. Okay, so it might take a little bit off if they're trending down, or add a little bit to it if they're going up. Okay, so nothing that you guys would have to do other than just make sure that you're pushing the use CGM button and then confirming this. And then it's going to give them the dose they would take, and you just would push the start. And again, it's going to send them a message to the pod. They can put this away. This can go back to you. They can go back to class. It doesn't have to be next to them while it's delivering everything. And then it's going to go ahead and give the bolus, and then it will continue to give those little micro doses based off what the blood sugar is doing. Okay. So again, just remember, if they've got the Omnipod 5, it is talking to their CGM and making adjustments. If they have the Dash or they have the Eros Original, these are strictly insulin delivery devices that are not taking into account blood sugar. Everything is done manually. Okay. All of the versions can be put into a activity, or I'm sorry, not all the versions. This one can be put into an activity mode, where it's going to change the target blood sugar, so it reduces how much basal they're getting. So it's going to increase the target to to 150. And so it's not going to be as aggressive in how much basal insulin they're getting. The other two versions, there's not an activity mode, but you can temporarily adjust how much insulin they're getting. Okay. Any questions from the folks? Have they had questions where they'll pop
Yeah,
up there?
they're more than welcome to ask
Okay.
any questions. We've got
Is
about
there-
15 minutes.
Okay.
So if someone's got a question, yeah.
I'm sorry, was that too fast?
No, you're great, Leah. We're very grateful.
Okay,
that
sometimes
you're
my
here.
pace goes Anything that you feel like would be good to touch on that
Yeah, I think the reason why she's showing you, I'm sorry, I'm not on the screen, but the reason why she's showing you the 3 different devices is Omnipod coverage by insurance is very different.
Yes.
And so we are slowly seeing more insurances covering the newer models of the Dash and the 5. But you may see someone with, Medicaid insurance on that
on the
Narrows,
older version.
especially like Mississippi Medicaid.
Yes.
But Catherine, one of our educators who's also on this, is working diligently to try to figure out a system to see if we can get patients on the 5. So you might see patients go back and forth between the devices depending on what they've already paid for as far as their insurance coverage. So if they already paid for 3 months of the Dash supplies, but they were really excited to go on the 5, they may revert back to the Dash to use up their supplies just because they have them or something of that nature. So you may see children go back and forth between these different devices. So that's where it's really good that we need to talk with the parents, or if you see one of these different what we call PDMs, so personal diabetes managers. So the 2 that she showed you originally, or the phone, it's like, okay, so which one are you using now? Because we need to be a little bit more aware of the different functionality of the different devices.
Correct.
Yeah.
That's a really good point. And so in the pods, it's important to note that it's a different pod for each different device. So the pods look the same, but a pod that works with this version won't work with this version. And then since the pod that works with the Omnipod 5 is talking to the Dexcom, so it has extra software in it. On someone's body, you couldn't tell. They would all look the same. But just important to note that if the child is moving from one version to the next, that they're matching the right supplies up with the right version. Because it wouldn't pair when they tried to turn it on, it just would say it didn't connect. So yeah, that's important to note. And it's insurance based. Of course, everybody wants the new one, and we're hoping, to get that more streamlined where everybody will get it, but some insurance plans only will cover this guy, which is still great. They're still getting a tubeless insulin delivery system, but we know that everybody wants to have that integrated system. So working towards that for sure.
And then there's an age bracket as well. So what is the 5 coverage?
So the 5 coverage is for 6 and up, but the preschool trial, I believe they finished that trial, so they should get the lower. Then it would be 2 and up, but currently it would be 6. So you're school aged. I don't know if y'all do pre-K.
Yeah.
Some pre-K nurses on there, so
right.
they might not see it, which it could be at doctor's discretion. So you may see a physician that wrote it for them and that their insurance covered it.
And the Dexcom for the 5 has to be on the same plane as the body?
Yes, that's important. So the Dexcom needs to be in sight of the Omnipod. So some of the sites that you can wear the Omnipod from this. So we would just want to make sure that if the patient was wearing the pump on their abdomen or their leg, that then the Dexcom would also be on the same side of the body and in line of sight. If they're going to wear either their Dexcom or their pod on the back of the arm, then they would want to have a back of the body sight, okay? Just so that they can talk to each other easier. And that's, what we recommend. I've already seen some patients not necessarily doing that feel like it's working okay, like on the back of the arm and the abdomen, and then it seems to talk fine, but that's not a recommended placement. That's not something that we can say is going to communicate as well as it needs to. So we want to have them in the direct line of sight. And the pod, of course, we want patients rotating their sites. We don't want them wearing out of place, only wearing it on their abdomen or something like that. So with the direction of the pod, it could be placed on the arm going up one time, and then 3 days later they're going down. As long as that insertion site is being moved a couple of inches away, we just don't want them to build up scar tissue. And sometimes with the little ones, especially if they don't want people to see, they don't, are kind of more embarrassed by it, they might want to put it someplace where it can't be seen. So they may be typically wearing it on their lower back or something like that, where it's covered up. But they just need to have it in line of sight with the sensor so that the 2 can communicate without any interference.
Any tips that you have for if you've got a kid that, because it is a sticker ultimately, for getting it to stay, or any tips for how to not get it kind of jarred and bumped around?
Yeah, so there's definitely a bunch of different products you can get this. You guys will get a copy of this PDF. And so it does have a list of different products. So when a lot of it's going to be before they change their site with their site prep. So hopefully they're coming with it already stuck on well. If it's something they're having to change at school, if you guys, I don't know if you guys keep stuff like that, or the parents can send in some that I like. Skin Tack is a popular product that helps just add some extra adhesive, or All Care Wipes. That's another one that just helps to prep the skin so that it can stick a little bit better. Making sure that the site is clean and dry. They don't have any lotion or oils on the skin, because of course that's going to interfere with it sticking. You know, if they're at school and they come in and it's gotten picked or pulled, and they come to have you check it and be like, is it still working? So it's attached. It's not flush to the adhesive, because our bodies aren't flat. So just because it's kind of up on one end doesn't necessarily mean that it's pulled out. That's when you want to do like smell test, check at the insertion site where the window is to see. So, you know, it could get just pulled up from back here. You could put either ace bandage or what's this stuff called? Like when you give blood, it's like the sticky stuff that they wrap around your arm. If you guys have that, you can wrap around it. You can put that around it. I've even had people put a Band-Aid on the back just to help keep it till they get home, till they can change it. Because of course you don't want this falling off, and this is essentially a pump. So they're replacing this every few days, and so it's got their insulin in it. If this gets knocked off and they just filled it up that morning and they're like, man, it's got all my insulin in it. Unfortunately, we cannot recommend that they would take the insulin out of here and fill a new pod. That's not something that the company has tested. So they would need to get fresh insulin. So you're not recommended to pull it out. But yeah, just checking it, just because it's gotten pulled up on one end doesn't necessarily mean that the insertion site's out and then they're not getting their insulin. And again, you could wrap it, you could put an extra bandage on it to keep it down. There's also patches that go over the whole pod and provide like an extra bandage around the whole thing. Those are something that parents might send in, or you may see the kid with having that on it. We don't necessarily recommend taping across it unless you're having an issue where it's come up and you're trying to do something afterwards. Proactively, we don't recommend that, because again, it doesn't attach to this adhesive flat, because our bodies aren't flat. So we want to give them that movement of the adhesive where the pod does not have to stay stuck, straight onto them. Okay.
And how often do they typically change those pump sites?
So it has to be changed at 80 hours. That's the maximum time that you can wear a pod. Most people are going to be on a 72-hour change where they're switching it on that third day. We do have some folks where they notice their absorption is not as great on the third day, so they may be on a 2-day change, or if they're on a lot of insulin, but that's not as common with your type 1s and with kids, that they would be on so much insulin that they couldn't get 3 days out of this, because it can hold up to 200 units. Most of the kids are going to be on a much lower dosage.
And is there a way to dismiss the pod change? So like you were saying, typically those pod changes shouldn't be happening at school, they should be happening at home.
Right.
But the kid might get an alert that they need to change their pod. Is there a way to dismiss that alert?
Yes. So if it comes up on the screen that it's going to give them a warning so that they're getting close to when they need to change it. So if it's based off the timing, their expiration is on the screen. I'll show you guys since this one's running. So down at the bottom, it tells you when it's going to expire. So pod expiration is at 8:40 on 8/6. Okay. So whatever the expiration date is on the controller, they actually have an additional 8 hours before it would shut off. So assuming that they still have insulin in their pod, they can push it for an additional 8 hours after whatever the expiration is on here. So that's a good point. So if it's got an expiration time of when they're at school, the typical day is 8 hours. So hopefully they would have enough time to get on home. It's not gonna, still give them their basal rate. They can still bolus. They can still do everything until they use up all the insulin in the pod. So as long as they have extra insulin, they can push it to 80 hours. So they can push 8 hours past the expiration time. The expiration time is a 72-hour, and that's recommended just so you're changing it at the same time on the third day. Versus if you do 80 hours, you're going to end up, at some wacky times that you're changing it. So it will be beeping at them and reminding them, hey, you're in your last 8 hours, you need to change it. But they can push through from that 80-hour point. Now, if they get to the 80-hour point, it is just going to shut off, and the pod will actually give them a loud beep. this is something. So if they do get a pod alarm, so say that the cannula gets kinked and it can't push the insulin in, the pod will beep at them. The controller will tell them occlusion detected, remove pod now. So they've got to go ahead and remove their pod and change it. So that's going to be the troubleshooting that you guys may have to do with them, where they came to school, everything was great, but for whatever reason, the pod got an error. It should not happen frequently, but it can definitely happen. So if the pod will not respond to the controller and turn off, there is a way to make it be quiet. So it would be off their body. It would still be beeping at this point. It would be just kind of like, ee. You flip this back, and I'll try to show you guys. There's a little green circle right there. And you take a paper clip or a safety pin and you just push it into that green circle, and that will make it be quiet. So if you've got a pod that's just making noise, you took it off the child, the controller says it can't talk to the pod for whatever reason. And on the controller, you said, okay, it's deactivated, go ahead and set up a new one, but you still have this pod over here beeping. You don't want a beeping trash can. So you just flip this back. And again, there's just that little circle that you're going to push a paper clip or a safety pin into, and that will shut it off so that it will stop beeping.
You taught me something today too.
Oh, good.
One of our former nurses, her son has diabetes, and she said that they would just throw it outside or run over it. Or
Yes,
like, do whatever
you
with
can run
it.
over them and it will not shut them up. I mean, nails are tough. So
That's so funny.
yes, so that's how you can make it be quiet.
All right, well, we will, if anyone has any questions, we'll hang tight here just another second or two. And if no one does, then we'll take a 15-minute break and we'll get our next presenter on via Zoom. So I don't think I
Well,
see
thank you
any
guys.
questions. Thank you so much,
Yes,
Leah.
yes, I'm glad to
We
come.
so appreciate you. And
Yeah.
at the end, you'll get some contact information for Omnipod. So if you need to reach out to them, if you have more questions, especially with this new technology, the new algorithm that's out, then we will get you hooked up with them. All right, we're going to take a 15-minute break and then we will be back.
Thanks, guys.
Hey, Catherine and Erica, I just want to confirm, can you hear my audio?
We sure can.
Awesome, thank you so much. Well, I'm going to go ahead and get started. My name is Megan Lindsay Tahiri, and I am the Clinical Account Manager with Dexcom. So today I'm going to be going over with you a little bit of information about the Dexcom G6 continuous glucose monitoring system. So thank y'all so much for having me. I really appreciate your time. So to start off, I really want to go over how continuous glucose monitoring has really been revolutionary in changing the way people with diabetes, really take care of themselves and take care of their diabetes. So as you see here, CGM and BGM are very different. CGM really provides better insight into the quality of glucose control that a patient has. So these 4 dots here represent, a blood glucose reading during the day. As you see, there is a lot of time missing where you're not getting a lot of information. So flash forward to CGM technology, and with the Dexcom G6 system, you get 288 readings per day if you're wearing it. So it really gives you a lot of insight into right here where a big spike was missed if you would have just been looking at blood sugar patterns. So this really allows you to be more proactive in your diabetes care, and you're able to really get super granular, and the patient and their clinician are able to make some changes that's really meaningful to help keep them in good control. So Dexcom G6 is approved for ages 2 years and up. And we are a very interconnected system. So I'm sure y'all have heard from Tandem and Omnipod. So our CGM does work directly with those pumps. So the insulin delivery is based on the Dexcom CGM numbers that the system is connected with. So a little bit about the system here. So CGM systems use a tiny sensor that's inserted under the skin to monitor glucose levels in that interstitial fluid. So Dexcom's a calibration-free device, so no finger sticks are needed to teach the system its accuracy. So I'm going to go over just some of the parts. This is the sensor you see here. It's very tiny, so it's inserted under the skin with a needle. The needle retracts, and that little sensor that stays under there is what measures glucose levels in that interstitial fluid. And if you haven't seen one of these, this is what the applicator looks like. The sensor is built in inside, and there's adhesive that keeps it on for the 10-day wear. And the little piece that goes on top that's gray is called the transmitter. And that transmitter transmits glucose from the sensor to their designated display device. So in school, you may have a receiver that the patient, or excuse me, the student uses to view their glucose levels, or they may use their cell phone, an app on their cell phone, either an Android or an iPhone, to be able to see those numbers. So with the Dexcom system, you're not only getting where the student is in the moment, so every 5 minutes they receive a new reading, but you're also getting speed and direction, or what we call a trend arrow. So this tells the patient what their blood glucose levels are going to be within the next 30 minutes. So each arrow is different, and every CGM system out there, their arrows are different and represents a different rate of change. So I know I attached a sheet that kind of has this information for you, and you can always ask me questions after or email me, but as you see here, if your blood glucose is slowly rising or slowly falling, that means in the next 30 minutes, you're going to be 30 to 60 points lower or higher. If you have one arrow up or down, you could be 60 to 90 milligrams per deciliter lower or higher within the next 30 minutes. And then if it's rapidly rising or falling, you could be 90 or more points higher or lower within the next 30 minutes. So this allows, the patient to really hone in on, preventing those lows and preventing those highs, and able to dose insulin more appropriately to counteract that. So this is what the display device looks like. It shows a cell phone here, but the cell phone and the receiver mirror one another. Students can use both as well. You know, typically they only carry one to school, of course, but they can connect both. So it does show you right here the glucose level at the current time, and then the trend arrow where it's going. And then as you see here, this is their kind of trend graph is what we call it. So it depicts the last 3 hours of glucose, and the gray area is between their target range. So you're able to really visually see if they're staying within that target range. The yellow represent their high alert level if their glucose has exceeded that or in that area. And then the red is the low alert level. So you would be able to see if any of those readings within the last 3 hours have fell below this threshold. So just some considerations, you know, and everyone's 504 plan will detail the information that I'm speaking about, but, you know, if the patient uses a smart device, it will need to be connected to Wi-Fi. And also, you know, you will need, the student will need to have their alarms loud enough to hear those low and high alerts. And unsure how your school responds to, you know, students wearing these smartwatches, but there is the ability to connect the student's smartwatch to the Dexcom G6 app. They do have to have the cell phone close by to transmit this information, but students can also look at their watch face and be able to see what their current glucose level is. Another consideration with Dexcom in the school system is Dexcom Share. So Dexcom does allow you, if you're using your phone, to be able to share your glucose levels with up to 10 followers. I know I've had some school nurses reach out to me and ask, you know, what's the deal with following? Should we be following, you know, the students' glucose levels if they ask, you know, the parents ask to share it with us? And I think that's totally up to the student's 504 plan, and as well as up to your policies and procedures at the school. I know some schools completely are against this, and then some schools do it for, you know, certain students as well. But they can share their glucose levels, so parents really like this ability, and the student will need Wi-Fi if they are going to share it with their followers. So they will have to be connected. And then Follow is the app that if you were to follow a student with the share function, this is the app that you would need on your iPad, the Dexcom Follow app, to be able to see those glucose levels in real time. So just some considerations that you may encounter when you have a patient with a CGM or wearing a CGM. So Dexcom does provide those high and low alerts that allow an audible alert that happens when a student goes below their glucose low or above their glucose threshold for high. So, you know, really we encourage clinics and encourage parents when we're talking to them about the devices to really set these alerts sparingly, and the alarms, you know, setting them at a number where it requires that immediate reaction by the student. And these are very customizable. So some of these you'll be able to do, you know, vibrations. Some of them you will have to have a very loud audible sound. So it's totally up to the parents and the students what's in their 504 plan of what their thresholds are, and each student will be different. So you may have to respond to these high and low alerts. There's also an urgent low alarm that is a non-negotiable with Dexcom. So it will beep if the patient is 55 milligrams deciliter or lower. So you may be asked to respond to this alert as well. And then there's also an urgent low soon alert, which some students like to have, that alerts the students that they will be 55 milligrams per deciliter or lower within the next 20 minutes. So it's a great predictive alert. And so in someone's 504 plan, they may have, if the student has this alarm on, you know, we want to treat them for hypoglycemia when this alarm comes on. Even though they're not low yet, we want to prevent that from happening. So again, very individualized. Some students don't turn this on, it's individualized. So these students may come to you to respond to these high and low alert levels. And then also the trend arrows. So you will be using the trend arrows in determining possibly the mealtime dosing treatment. And then you could be also using the trend arrows in determining treatment for hypoglycemia as well. So how many carbohydrates to give them if they're low based on where they're at the current moment and which trend arrows are in place. So for example, for the patient lunch, if they come to you to get the insulin dose, if your patient's blood glucose level is 150, but they have two double arrows going up, you may have to give more insulin based on their 504 plan. And I apologize, I keep calling students patients. It's just a bad habit. So any steps that you should take if you are responding to the alerts and alarms on the receiver, of course, are in the 504 plan, but you always want to make sure that you tap on the OK button within the student's device, because if you don't, it'll continue to beep and alert until you respond to this. And then there's a threshold where it alerts again if the patient is continuing to be high or low within the next 30 minutes. Another consideration that you may have with a student is you may be asked to put some adhesive over the Dexcom G6 to make sure that it stays on. So we do provide over patches for students as well as any Dexcom users, but your parents may have or guardians may have another type of patch that they like for their children to wear. So if it starts peeling around the edges, you can use those tapes to securely, place it to the body. And we never want to tape over the transmitter or any of the plastic parts of the sensor pod because it can damage it. And we have some really good resources that I can send to y'all as well about, which adhesives are popular with this population. And then next, you may be asked to insert a sensor. Again, this is all in your policy and procedure and 504 plan, but I just kind of wanted to give a little depiction of what this looks like. There are some great training videos that we have on our YouTube channel and on the Dexcom website. So what you would do is, gather your materials, make sure the sensor site is clean with an alcohol wipe, let that dry completely. For ages 2 and up, patients can, in their upper buttocks area, place it there or in their abdomen area. And you just want to peel off those adhesive backings, place the adhesive on the skin, fold and break off the safety guard, and then you're just going to let off pressure and then press the button to insert the sensor and discard that applicator. Then you'll attach the transmitter on top. So the feet go into the hole is what I like to say. There's a little tab on the transmitter that goes into the slot, and you'll hear a double click when you place it flush down in the sensor pod holder, and then you'll rub around the patch 3 times. What's great about it is if you do have to change one of these, the app and the receiver walks you through every step you need to take. And there's also videos within the app that shows you how to do it. And then lastly, you may get the student coming to you because there's some weird alarms. Maybe they've never seen these before, or this is happening again and again, such as signal loss. You do have to be between 20 feet of your device to be able to get glucose levels transmitted. So I know a lot of schools have problems, and maybe if their Wi-Fi is not working as well as it should, or there's a lot of thick walls between where the student's at and where their receiver is at. So we want to make sure that they do stay within 20 feet of the device. And in both the receiver and the cell phone, you can tap the help button, and it gives you exactly what this alert and alarm means and what to do to help, to help this alert that you're getting here. And then you can also look at the Dexcom FAQ section and you can type in signal loss and it'll take you right to the information of how to regain signal loss or maybe sensor error or something like that. And as always, if you have any questions about that, you can email me or any of the wonderful people at the hospital as well. And then this is my information. If you have any questions, please feel free to email me. Dexcom technical support is also open 24 hours, 7 days a week. So this is the number listed here if you do happen to have any questions.
And we've got a few minutes if anyone has any questions for Meg right now that we could have her answer. We also have our other educators on the Zoom, so if they have anything they want to add to, they can. We'll just stay on for just a couple seconds, Meg, and then we will transition over to our next presenter in a second.
Thank y'all so much for
Thank you,
having me.
Meg.
Anna, one of the educators, can you hear me fine?
Yeah.
So there was just one thing I wanted to add. Sorry, 1 second. Okay. So I know we've kind of been going over like insulin pumps and Dexcoms and different types of CGMs. We'll continue going over that, but just for the school nurses to hear, with these insulin pumps and Dexcom or other CGMs, for our kiddos that are on like, you know, mealtime insulin as well as like long acting or needing insulin for meals, the kind of main way they get insulin is typically through injections and finger sticks to check the blood sugar. So insulin pumps or CGMs, they're just kind of like added features if you want to use them. So like they're not necessarily required. So you may have a kid come in on injections and like a meter, like using finger sticks to check their blood sugar, and that's perfectly fine. So I know I've gotten a few calls before, like, hey, they ran out of like their CGM supplies, like what do we need to do? And they can go back to finger sticks while they're waiting for that supply to come in. So I know that's been a concern before, but these are kind of just like added bonuses. Now, if it's a pump and they run out of supplies, yeah, that's a different story because that's how they're getting their insulin. But I just wanted to clear the air on that. And if there's any questions you'll have about that, please let us know.
That's a great point. And we encourage at Dexcom for them always to have their meter with them as well, because you never know when one may fall off and they're not allowed to put it back on at school. And I think I skipped over this part, and if I have quickly some time,
Yeah, go ahead, Meg.
You can make treatment decisions with the Dexcom G6, but there are certain times when we do encourage using a meter. The first time, as you see here, is if a number and an arrow are not shown on the app or the receiver. We do encourage them to, if they're about to give insulin for dosing, then definitely use a finger stick. And then, of course, if their symptoms that they're having don't match the number that they see on the screen, we want them to do that confirmatory finger stick. It's a safety thing. We want to make sure that, they feel right. Students know their symptoms. And so we want to always trust them and what they're feeling over what they see on the screen.
All right. Thank you so much, Meg. If we don't have any more questions, then we'll just take a brief break, and we're just going to swap our presenters over so that we can hear a little bit more about Freestyle Libre. Thank you so much, Meg.
Thank y'all. Have a good rest of your day.
You too.
Okay, can you hear me?
We can, Kim. We can't see you, but we can hear you.
Okay, let's see. So I may have to go to my iPad. Let me see.
Okay.
It says video's going. I'm using a borrowed laptop from work. Mine died. Do you know where I make it? Come on. What? Any suggestions out here?
Yeah, you should at the bottom of your screen have a little area that says start video.
It's going. It doesn't now. It's showing like says stop video. Let me try my iPad.
Okay.
Do you want me to bring Stacy back here in the big room?
Sorry about this. To our
So sorry, y'all.
just hang tight just a second.
Right, let me launch. So I'm talking about Freestyle Libre. I can talk while I'm trying to get on here. Launch meeting. Let's see. Open. Let's see. So Freestyle Libre is the other CGM on the market. Okay, I'm coming in. See if it'll let me. Okay, there you go. Can you see me? Now? Does that join? No, join. Oh, go back. Leave. I'm so sorry, y'all.
Okay.
I want to cancel out. I accidentally hit click join without video. Freestyle Libre is the other CGM on the market that you wear for 14 days. And it goes on the back of your arm. Let me go back in. I'm so sorry. Okay. I'm open, join meeting. Okay. Join video. Can you see me now? Now can you? Okay. Can you hear me? Okay. Join audio. Recording in progress. Okay. Can you hear me?
Yes.
Okay. So thank you. I'm so sorry, y'all. So my name is Kim Vance. I am a registered nurse and the diabetes sales specialist for Abbott. So I'm going to talk about Freestyle Libre today. So hopefully you're familiar with this sensor as well. So this one is one that you wear on the back of your arm. So this is the size of our sensor that goes on the back of your arm. It's you wear it sub-Q fat. So it's going to check a blood sugar every minute. So but you still have to scan with ours. It's not Bluetoothing straight to your phone or to your reader. So we have a reader and we have an iPhone app. And for pediatrics, it's for 4 and up. So we have the reader, which is here. Hopefully most of the kids will be using maybe an iPhone, but not everybody has the phone app. But I will show you how. So here's our reader. And as long as they scan one time within 8 hours, our reader or our phone app is going to collect all their data. So it's checking a sugar every minute regardless. So all you'll do is if they have a reader with them, we're going to check the blood glucose, and then you just wave it over the sensor. Let me hit check glucose here, and it's going to give you your reading. So I've got 106. Ours has the alarms as well. We have a low alarm, we have a high alarm, and we have out of range. And if they're using the phone app, there's also the urgent low that you cannot turn off. We also have trend arrows. So I'm going to show you a picture of those. I'm sorry, I have no slides. I'm filling in for my coworker who has COVID. So we've got if the trend arrows are pointing straight up, it's going to say that means the glucose is rising quickly. If it's just kind of going at an angle, it's slowly rising. If it's going straight across, we're slow and steady. So that's a good blood sugar. We've got the one arrow going down that tells you they're slowing, the glucose is falling. And if it's going straight down, they're dropping quickly. And sometimes it will give you the icon telling you to do a blood sugar check just to compare to make sure what the blood sugar really is. And our reader actually is a meter as well. So there are strips that come with this reader. But the phone app, with our Libre app, there is a link up app. I'm so sorry. Where the you can have up to 20 followers. I'm sorry, my iPad's falling, y'all. You can have up to 20 followers at a time to follow along to see what their blood sugars are. And they're also going to get those alarms but you have to scan. If it gives you an alarm that you're having a low blood sugar or a high blood sugar, they have to scan to see what the actual reading is. And I want to show you let's say it falls off and they have an extra one with them at school. It comes with this is our sensor, and it comes with an applicator. They're so easy to put on. It's the easiest CGM, I think, out there on the market. So you got your sensor in the pod. So you just tear this off. And then we have our applicator, which you just twist apart. And we have a line, and there's great YouTube videos on how to apply a sensor as well. So you're just going to line up these two lines together to collect the sensor. You like to do it on a hard surface. And once you put those together, we have our sensor in there. So with every box, there comes 2 alcohol swabs come in there. So we definitely want to use the alcohol swabs to clean it off, make sure it's dry, to get all the oils or any lotion or anything off. And then all that you do to put it on is you just put this up to their arm and push it till it collapses, and we're done. So it's super easy to put on, and then you'll scan, and then it takes a 1-hour warm-up period for that to start working. After 1 hour, you're able to start scanning to get the blood sugar readings. We are not integrated with any insulin pumps yet, but we do have a new sensor that's coming out, hopefully in the fall, maybe for the spring, that will be maybe at one point integrated with pumps, but also there will be no more scanning. It will Bluetooth straight to your phone. So I'll definitely show you the difference. This is going to be the Libre 3 compared to our Libre 2. So this one will be the smallest, most discreet, thinnest CGM on the market once it's out this fall. We're trying it out in some of our endocrinologist offices now, but this one will Bluetooth straight to their phone every minute once we get it out. So it will be great for patients using their phones because there's no reader will come with that one. Let's see, what else can I tell you? Do you have any questions? I feel like I'm rambling to y'all. Anything? Any more I want to tell you about? Let's see. Oh, let me show you how. So if you do have a patient with the reader, you can go in and review their glucose history. I don't know if y'all can see the reader very well. Hopefully most of your patients are going to be using the phone app, which is the Freestyle Libre 2 app. Y'all are my first people to present to on the Zoom call. So I'm going to go to the home screen on the app and show y'all. So go back to the home screen, and it says check glucose at the bottom. So I'm going to hit check glucose, and then you just scan with the back of your phone. With an iPhone, you're just going to touch it to the sensor. I'm getting a sensor error right now. It told me to try it again in 10 minutes, but it's super easy to use. The Android app sometimes is a little bit more, or the Android phones are a little more complicated. You're going to scan from the middle of the phone as opposed to the iPhone. It's going to go from the top of the phone where the camera is. They can get this wet. They can swim in it. You can go 30 minutes, 3 feet of water. We also have Tegaderms. You can put a Tegaderm extra coverage over those, especially in these summer months. It's really hot. People are sweating, and you've got children out running around. So we'll sometimes suggest they use the alcohol swab, then use one of the skin preps, and then they can also use a Tegaderm over it to keep it on their arm. If it falls off, it's done. We can't put it back on. What else can I tell y'all about it? I don't know. Do you have any questions? Anybody? Or Erica, or y'all have anything else they need to know about it? It does need to stay within 20 feet of you. So their phone or their reader does need to be within 20 feet so they can talk to each other. But we encourage everybody to scan, at least 4 times a day with it. You can scan up to 100 times a day. That does not matter. So you can see how their blood sugars are doing all the time. And the alarms you can have to vibrate, you can have them to noise, and you can also customize those as well, because we don't want people getting alarm fatigue or sitting in class and alarms going off. So you want to make it right for their child.
And Kim, one of those readers has the availability to have test strips in them.
Yes.
But
Yes.
a lot of our patients don't use this as a meter. They have
Correct.
a separate blood glucose meter that's covered by their insurance.
Correct.
So typically they wouldn't have test strips that would go in that.
You're right. They can get them at Walgreens, but they're special to this reader. Yeah, they're Neo Precision strips. So a lot of people don't use that one. You're right. They'll probably have their own meter and strips to the side. I just want to see if it'll let me scan again. That was my Libre alarming at me right there saying, let me try again. And you can even have this on Audible. It'll say you're reading out loud. Because hopefully I won't have visually impaired patients, but if you do, when you scan, it will say the reading out loud and tell you what the trend arrow is doing with the phone app.
And then, I'm sorry, I had to step away, Kim, but
No, please do.
did you say that it does not at this time connect with any of the insulin pumps?
It does not, but that is what we are hoping for down the line. But the Libre 2 definitely does not. And hopefully Libre 3, once it's launched next year, will have some connections with the pumps. So it does not communicate with anything except for an iPhone right now or an Android phone.
And excuse me, one other thing about Freestyle Libre that is interesting is their pricing. And so
Yes.
a lot of times if a CGM is not covered by insurance, then they do have a out-of-pocket maximum cap. And what is that, Kim? Is it like $75?
It's $75 for 2 sensors, cash pay. And a lot of times the GoodRx card brings that down into the 60s. So that's even better. And we're a third of the cost of our competition. So it's like the CGM for everybody. If the insurance doesn't cover it, a lot of times you can afford to pay cash pay for it. And at all the big box pharmacies, the CVS's, the Walgreens, the Kroger's, we have a built-in coupon in place with their computer system. So no one should pay over $75 with their insurance. So if they're asked to pay more than $75, we have a phone number they can call to bring that cost down to $75 for 2 sensors. Some people may pay nothing. Some people may pay 25 or 30. It all just depends on their insurances.
And so one interesting thing that the school nurses will find in the school care plans is we do not mandate that they have one or the other. So they could potentially go back and forth between the two CGMs that we've seen due to cost.
Correct.
And so they could start out on Dexcom, but flex to the Freestyle Libre because of cost or coverage or insurance or loss of insurance, lots of different things. And we see this one a lot with our type 2 patients as well. It tends to cover that a little bit better, or those patients, their parents choose to pay out of pocket that $75 so that they can have a CGM even if insurance doesn't cover it.
Yes. So yeah, these are great for type 2s for sure. Because not a lot of patients, if you're not on insulin, they may not want that CGM. But it's, and I keep on talking about Medicare, but you aren't Medicare patients. Y'all don't need to know about that. And the newest one will be so much, I think everybody's going to love it. It's so much smaller. I'll show you one more time. It is so tiny. So it's like 2 pennies stacked on top of each other as opposed to a quarter. So, and the fact that it's going to Bluetooth straight to the phone, everybody's going to want Libre 3 when it's available. It's not out in the pharmacies yet.
Yeah,
but
so
soon.
We'll probably see that come
Yeah.
more to light in the spring, like once you guys come back after Christmas. But that product and even the current product are really appealing to those teenagers who don't really want anything seen because they are so
Right.
small.
And they can scan straight through their clothes. They don't have to pull their arm up and scan. They can scan straight through their clothes. It's very discreet, especially if you're using your phone. It's not very noticeable what they're doing.
Definitely. Do any of our other educators have any questions or comments or? things we want our school nurses to know?
You could have all 20 teachers following them at one time if they wanted. Nobody's gonna want that.
Yeah, and that's something we'll talk a little bit more about later, as far as like depending on how many students you have that have diabetes, that might be a pro or it might be a con, as far as really being able to
Right.
respond to the app and following and all those kinds of things.
I'm sorry if I rambled, y'all. Sorry.
That's okay. That's okay. All right. Well, I don't think that we have any questions. So unless you've got anything else, Ms. Kim, we will.
I think
break.
I'm good. Please reach out to me. I'm happy to tell you any more about it. They can email me or call me. That'd be fine.
Yeah, we're definitely going to be seeing more and more of this product as we go along. And so you're going to be seeing this more and more with your patients. And so definitely a new product. But all right, well, we are going to break for about 10 to 15 minutes. And then once we come back, we'll have Medtronic present. Was there anything else you wanted to do, Kim?
I'm good. Thank you. I'll just say one more thing. Like when you use all this, everything goes in the garbage. It's a one and done. You start over every time with a new box, with a new applicator and a new sensor in each box. That's it.
Yes. That sensor can be a bit intimidating to look down. A lot of
Yeah,
us
if you look at
have
that,
more
you're right. You're right.
So definitely that the whole needle does not go into them. Sometimes.
Yeah, I'll explain that too. What stays in their arm is no bigger than 3 pieces of hair. So people are like, I don't want a needle in me. I'm going to feel it. They worry about it, but it's no bigger than 3 pieces of hair. And also this is reading interstitial fluid versus a finger stick. And one of the hardest things to do is patients want to stick their finger and scan and get the readings could be 30 to 40 points off, because one's reading interstitial fluid and there's a lag time between what you're going to see with that scan and what an actual blood glucose is going to show. So we just encourage people, unless your reader or your phone is saying you need to stick your finger, just trust the reader, just trust the sensor, because it's very hard for people to go, well, it's not the same and I got to take insulin, but just trust what the sensor is saying and don't poke your finger unless it advises you to do so. And
that's fairly new that the CGMs are trustworthy enough to dose off of, and that hasn't been past recommendations. We actually are going to send a new education sheet to all of you guys after the presentations from the American Diabetes Association. They have new recommendations for schools. I know Tipton County, Miss Cindy Hawk, she says like that is what she goes by, is the ADA standards as far as how they really implement some of these things into their daily lives with their patients. And so those resources from the ADA are very, very helpful. So it includes the Freestyle Libre as well as the Dexcom, and then Medtronic will present on the Enlight sensor as well. So exciting things for kids.
It is.
Yeah. All right. Well, thank you so much, Ms. Kim.
Thank you. Thanks for bearing with me. I appreciate you give me some time.
Absolutely. We're going to take about a 10 to 15 minute break, and then we're going to get Medtronic pulled up. So thanks so much.
Thank you.
All right, you can go.
Hey, everybody. All right. All right, everyone. Hello, my name is Kristen Bettis, and I am with Medtronic Diabetes. I'm a registered dietitian, and I have been with Medtronic now for about 14 years. So for all you school nurses out there, I've probably worked with a lot of your students. So today I'm going to present on the 670 and 770 systems so that y'all are a little bit more familiar specifically with button pressing when school starts this year. And then we'll also move into a newer product that you may not have seen yet, but you probably will in schools this year, is the InPen Smart Insulin Pen. So let's get started. Well, I say that, hang on. There we go. All right. So for the MiniMed 670 and 770 components, you can see here in the picture or illustration, it requires the pump and infusion set and reservoir, and for CGM, the transmitter and their sensor. It's always a good idea for every student to have extra pump supplies at school just in case. Specifically the infusion set and the starter for that if needed. A lot of these infusion sets now come with built-in starters, which is very convenient, and then also a reservoir. The 770 and 670 systems have two modes of functionality, manual mode and auto mode. For manual mode, the pump is using traditional pump therapy where it is using the pre-programmed rates that the providers at Bonheur have entered into the system for the student. It does require bolusing with the bolus wizard, or it can use manual boluses. And in the manual mode case, it may be used with or without CGM. For auto mode, that is when the system is automatically adjusting the insulin or basal insulin delivery based off of the student's sensor glucose values. These rates are adjusted every 5 minutes, and it does require bolusing before meals using the bolus wizard feature. Important information to be familiar with about auto mode. One, that the basal insulin delivery is based off of the student sensor glucose value. So proper and good sensor performance is necessary. Auto mode uses a target of 120. However, a student can temporarily change that target to 150, for example, physical activity. So if it might be PE or some other type of activity, maybe outside, there is a feature called temp target where the patient can go in and flip that to 150, where it's a little bit more conservative for those basal adjustments, allowing physical activity to play a part on lowering their sugar as well. Carbs need to be entered into the pump before meals in auto mode. So I know it's very common to see students bolus after the meal because they're more confident in what they've actually eaten. But in auto mode, you do need to put the carbohydrates in before they eat. And the reason for that is that when the patient starts to eat, immediately the auto basal starts to go up, which means the student would be receiving a higher basal insulin delivery had they would have entered in the carbs before. And so if that happens, and then at the end of the meal, the student goes in and puts in a large carb count, well, then that can cause the student to bottom out on the back end. So to prevent that, you want to make sure that they put the carbohydrates in before they eat. BG checks are still necessary to calibrate our system, but that will not last for long. Once the 780 and G4 come out, that will go away. But for now, the system still does require at least one calibration every 12 hours. And then, of course, we always recommend that patients give a calibration before they go to bed so that that 12-hour timing doesn't wake them up in the middle of the night, which most calibrations may not be done at school unless the system requests it while they're there. If a student enters in a blood sugar reading to the system that's greater than 150 in auto mode, it may recommend a bolus correction. And the rule of thumb is that you take it. The system is a little bit smarter than we are. And all that correction bolus does is help the pump to stay in auto mode. Now, the student may at times receive what is called a BG required alert. That can happen if the patient is going into auto mode, or it can happen while the student is in auto mode. And that is simply a diagnostic check to update the health of the sensor glucose value. So again, auto mode is completely dependent upon sensor glucose values. And there's a diagnostic chip that is in that small, tiny little shell piece, the transmitter, that's constantly checking the health of that sensor glucose value. So if at any point in time, the pump senses that the sensor reading is more than 35% different from the actual blood glucose value, it will say BG required. The student just simply needs to give it a BG reading and not calibrate at this time at all. So simply do not calibrate. You just go to the selection that says done, and that will satisfy that diagnostic check. Now, when the pump is in auto mode, and again, just keep in mind, this is both for 670 and the 770 pumps. You'll see that the pump has a shield. Now, the shield can be blue, which is what it should be the majority of the time, but it can also be gray if the system were going into safe basal, which we're not touching on today. But it can also be red if the student themselves had suspended the insulin delivery. When the pump is in SmartGuard auto mode, again, the responsibilities for the student are to check the BG and calibrate the sensor as needed. They should bolus for the carbs before they eat. And they should respond promptly to alerts and alarms. And for you as the school nurse, your job or role is to assist students with these responsibilities, and then also to follow maybe the school health plan provided by Bonheur. Important things to know, that the MiniMed 770 system is Bluetooth enabled, whereas the 670 system remotely communicates to the meter and the transmitter via radio frequency. But because the 770 has the Bluetooth capability, the students are able to view their sensor glucose values and receive glucose alerts on their smartphone via the MiniMed mobile app. And then what also is great about that is that the parent or the caregiver has an app on their phone called the CareLink Connect app, so that the parent can track and monitor remotely what is happening with the student throughout the day. So that kind of takes a little bit of responsibility away from the school nurses, but it just gives the parent that visibility while the student's away, which is a very awesome thing to have, because in prior systems, we've not had that type of visibility. For the pump buttons, the center key is, well, what you're looking at here is the 770 system. And now I know that my screen is blocking this other picture. Can y'all, hopefully y'all can see that. But the pump buttons first are the select key in the center. Then you have the up and down arrow keys. Also the left and right arrow keys are there just to navigate the screen if needed. There's the back key. And then finally, you have the graph key here. And the difference between the 770 is that this button has that diamond shape on it. And then over to the 670, there's the little graph picture that is on the 670, but that's how you can distinguish the two. There's also a notification light, which is embedded in the keypad underneath the back button. You can't see it unless it actually flashes. Just know that it's there. But if the student got a notification, for example, like a low reservoir notification, low battery, or maybe even an insulin flow blocked notification, of course, the notification light would flash for that. And then there's the picture of the graph key for the 670. Now, when the student's not interacting with the device, two things happen. The backlight turns off. It's not that the pump is off, but that battery is what powers that color screen. And if the student's not using it, we don't want it on and depleting the battery. So the backlight would be off, but also the keypad locks to protect from accidental button presses. And so basically the pump goes into what's called a sleep mode. But to unlock the pump, you simply hit the center key, which turns the backlight on. And if you notice in the bottom of the screen beneath the shield, there's a lock symbol. That's how you know that the keypad is locked. So hitting the center key brings up a picture on the screen of the keypad down below. And what is highlighted is the key that you should push on the keypad, and that would unlock it. Now, if you accidentally hit the wrong key, it simply says wrong key press, try again. You select OK, and then go back and choose the correct button, and then it unlocks. Here's some button pressing example for when the student may be using the linked meter, whether it be with their 670 or the AccuCheck with the 770. But the student simply checks their reading, and then they hit that back button, and it sends that over to the pump where they confirm the BG reading by choosing yes. And then from there, it offers three options to calibrate the sensor: bolus or done. And if it's calibrating the sensor that the student wants to do, first, you always want to calibrate the sensor. And once that happens, it takes that option away and takes you directly to bolus, where the student can use the same reading to bolus with. And then the student simply enters in their carb count and then chooses next, and then chooses deliver bolus. And then it goes back to the home screen where you can see the bolus progression of the delivery. Now, it's very common to see students not using a linked meter. Different insurance companies cover test strips and have and are on different formularies. So depending on the circumstance, it's very common to see a student that may not be using a linked meter. But that's okay. They can still do all the same things, just manually. So the student will check the BG and manually enter it into the pump under bolus. And then they can select BG and dial in the blood sugar reading on from the meter, and then lock that in. It takes it down to the carb count, where they can then enter in the carbs that they're about to eat, and then it will go down to next. And then you choose deliver bolus, and again, it will go back to the home screen where you see the bolus progression. If the student was wanting to calibrate, it's going to bring up the screen offering them to calibrate the sensor if they would like to, if it's a good time to calibrate. So that's always at the discretion or choice of the student. And if it were a calibration that they would like to also use that reading for, just simply choose yes. And then it goes back to the home screen and shows that it's also calibrating. Bolus recommended. So I mentioned earlier that in auto mode, if the student enters in a BG reading that's greater than 150, the system may recommend a bolus correction, and that's simply to help out auto mode. And the rule of thumb is go ahead and take it. So it would have the meter reading on the screen. The student would confirm it by choosing yes. And then it says bolus recommended underneath the BG reading if it does recommend a bolus. And then the student simply chooses bolus, skips over the carbs, and then goes straight to next, where that calculation is only done for the high reading. And then chooses deliver bolus, and it goes back to the home screen. Again, showing that bolus progression line. Now, I'd mentioned also before that in auto mode, students can bolus for meals or snacks without a BG entry. Because theoretically what's happening in auto mode, the system is already handling what's happening to the student sensor glucose values going into the meal. And so the system doesn't always need a help with a BG entry. It simply needs to know what the carb count is that the student is about to consume. And they may do a BG entry for their main meals, but what you may see this done, or where you may see this done, is if the student is having a snack, or if they're getting a second helping, scenarios like that. But it is okay for them to put in a carb count without a BG entry in auto mode. They simply go to bolus, and under bolus, they skip over the BG and go directly to the carb entry, enter the carbs, choose next, and then choose deliver bolus, and it's done. Now, common alerts and alarms that you may see, specifically with auto mode. Number one, again, the student needs to read and respond to the alert promptly and clear out that notification. The most common alert that can happen in auto mode is that BG required notification. And again, the notification light would flash and the message would pop up on the home screen. But again, the BG required notification may be, is necessary for the student to stay in auto mode. So if that happens, they do need to go ahead and satisfy that. But again, this is not a time that the student should be calibrating their sensor. That is not a time that you want to calibrate. And what can end up happening if the student does that is that it can throw the sensor glucose values off. And if that happens, then they're going to get another BG required notification. And so again, you do not want to calibrate that time. Simply give it that diagnostic check and choose done. And then it satisfies that need. So again, you just hit the down key as instructed on the screen, choose OK. And if you have any other questions about alerts or alarms, you can find all of those on the medtronicdiabetes.com site. So if there's something that you see on the screen that you're not familiar with, before you start to do things like calibrate the sensor, which is the most common thing that a patient would want to do to help, there are some alerts and alarms where there's nothing that the patient can do, and the system just needs to handle it on its own. So again, you can find those on the medtronicdiabetes.com site. All right, so using the pump in manual mode. So we've discussed auto mode, now we're going to manual mode. And what you've probably noticed is that the screen on this pump is a little bit different. So this is what the screen would look like if the student were using the pump strictly for delivery and no CGM, no auto mode. So to give a bolus in manual mode, the student would go into the main menu, go to bolus, choose bolus wizard. This is all probably what y'all are most familiar with. And here, the BG value would already be entered, or the student can manually enter it in, and then lock that in, going down to the carb count, enter in the carb count, and then arrow down to next, and then choose deliver bolus. Now, one of the other things that a school nurse might need to do would be to maybe check for the last bolus a student had given themselves. To do that, you go into the main menu and you arrow down to status. Underneath status, you can choose the selection quick status. And right there, there's additional information other than what you see here. But you can see that last bolus pops up on the screen, and you can see when that last bolus was given. You may also need to see other boluses, and you can do that by checking the bolus history. And you go into the main menu, down to options, which takes you to the next set of menus. And there's history, and you go to daily history, choose the date that you are reviewing, and from there you can see the most recent boluses that the student has given themselves. Things to remember: a student's responsibility: check BGs, calibrate the sensor, bolus for carbs before meals, deliver correction boluses as needed, respond promptly to alert and alarms and clear out those notifications. And again, follow the protocols for treating hyper and hypoglycemia based off of the school plan from Bonheur. Also to remember, we have our 24-hour helpline that is available 24 hours a day, 7 days a week, 365 days a year, all holidays. And the number can always be found on the bottom of the student's palm. So if you could not get a hold of one of us or the parent or even Bonheur, then just know that that 24-hour helpline is available as a resource. Additional support and resources, go to the Medtronic Diabetes site, and you can choose at the top left support, and then to the far right, you can choose healthcare professionals, and you can find all types of different resources that you may be able to benefit from, including a school nurses guide to both our 670 and our 770 systems. Also, always rely on the American Diabetes website as well as JDRF if needed. All right, so we've completed everything for the Medtronic pump side of things. And so now I'd like to introduce you to what is called the InPen Smart Insulin Pen for patients that are on MDI. So an overview to begin with, you may be asking yourself, well, what is InPen? Well, InPen is it's the first FDA cleared smart insulin pen with an integrated app. It's very simple to use, has been shown to improve clinical outcomes and reduce missed doses. It uses Bluetooth technology and is compatible with both Apple and Android smartphone devices. It also pairs with Bluetooth meters, Apple Health Kit, Dexcom G5 and G6, and our standalone system for CGM, the Guardian Connect. It's indicated for all ages, including children under the age of 7, as long as they have adult care supervision. And it also tracks active insulin on board and logs doses. So ultimately, this pen is truly designed for all patients on MDI. Some basic facts about InPen. It does deliver in half-unit increments up to 30 units of insulin per dose. It is compatible with Humalog, Novolog, and Fios, all strength U100, and it uses 3 ml pre-filled cartridges. Disposable needles are also used. It has a 1-year warranty, and it does use a battery to power it, but does not require charging. And that battery has a 1-year life from the time it is paired with the student's mobile device. It comes in 3 colors, blue, pink, and gray. It also integrates with CGM with both Guardian Connect in real time and also Dexcom. It does have a 3-hour delay with the Dexcom, but again, it still integrates with the Dexcom. Also, Bluetooth enabled blood glucose meters through the Apple Health app. The InPen is covered as a pharmacy benefit under most commercial plans, and multiple pens can be paired to the InPen app. So if you think about challenges that a student has with MDI, one of the very biggest challenges is, students can miss doses. I mean, patients in general on MDI, it's very, common for a patient to miss a dose. And what we have found is that when a patient misses at least 2 doses in a week, that can lead to an increase in A1C almost up to 0.5%, which is quite significant when you're looking at A1C numbers. Also, another challenge is that people need help calculating insulin doses, especially children. And we found that 2/3 of people do need help calculating those doses. Another challenge is having insulin on board. It's very common for patients to stack insulin on MDI, and studies have shown that 60% of those on MDI, those insulin doses have been taken with some insulin on board. And then also too, lack of accurate dosing information and reporting. And that makes it very difficult between both the patient and the provider when it comes to making therapy adjustments. And of course, that can be a barrier to optimizing that patient's glycemic control. So we've mentioned these challenges. And one of the ways that the NPEN app can help with meeting that challenge or these challenges, dose reminders. So the app has dose reminders that can be set. So for those patients that forget to take a dose, you can set dose reminders for all 3 meals. You can also set a reminder for the long-acting insulin dose as well. Maybe BG checks as a reminder before bed or after 2 hours after a meal. And then also a reminder for when the cartridge needs to be replaced. But setting up these reminders in the NPEN are really beneficial, especially in a student or a child's case. I know when I first got my pair of glasses, I would leave them on the nightstand every morning when I was in 4th grade. So imagine what these kiddos have as responsibilities and what they need to remember. So this is very beneficial to them. A dose calculator. So students and patients alike struggle with calculating how much insulin to take. With that being said, the app can track dosing, whether they be carb counting, whether they be doing a meal estimation for a dose, or if they are using a fixed dose for boluses. But what we have found with MDI patients is that when they use a bolus calculator, they report reduced fear of hypoglycemia, improved confidence in the accuracy of their bolus dose, and then increased treatment satisfaction while they're on MDI. And again, we found that the use of a bolus calculator is associated with a 0.7 to a 1% reduction in A1C. Again, incredibly significant when you are referring to A1C numbers. Now, accurate dosing data. So the NPEN has therapy settings for more precise insulin dosing. So one of the things that you may see as a student may have an insulin pump, but they may also have an NPEN as a backup to their pump. And the settings that are used in the Bolus Wizard and the pump can be programmed into the app to be used with their Bolus Wizard as well. But you can make it as precise as you want, whether the bolus be a fixed dose meal estimation or whether it be carb counting. You can customize, just like you do in the Bolus Wizard, the carb ratio, the sensitivity factor, active insulin time, as well as target range. Again, one of the more important pieces to tracking those accurate doses is the tracking of active insulin. And like I'd mentioned before, 60% of patients on MDI, those doses are taken with some insulin on board. It's just very difficult to mentally try to track. So again, the app can track that active insulin, protecting the student from potentially stacking insulin and going low later. And then last, of course, as I had mentioned, the diabetes app is integrated to different diabetes app, or the NPEN is integrated into different diabetes apps, and also to the Guardian Connect standalone CGM, as well as the Dexcom G5 and G6. So it's very nice that the NPEN is compatible with different technology depending on what the student may be using. All right, so that sums it up there. Thank you all so much. It was an absolute pleasure to be able to present to you all today. And if you'd like, this is my contact information. If you want to scan that QR code, it will immediately put it into your phones, and I'll give you a second to do that. And then I'm also going to give you Maya's contact, my territory manager, my partner's contact information. And if you would like to take a moment to scan that QR code as well, please do. And if you have any questions at all, please feel free to reach out to us or let Le Bonheur know that you're trying to get in contact with us, and we'll be glad to help any way that we can. So thanks again. Y'all have a good day.
Hey, Kristen. Hey, this is Anna, one of the diabetes educators. I just actually had a quick question. For the syncing to the phone, does it one pin sync to multiple devices, or is it just one at this moment?
Okay, so I know that there can be multiple pins.
Oh,
You're talking about the
can't hear you,
pin,
I'm
right?
sorry.
Correct. You're talking about the pin, the end pin? Oh, am I on it? No. Okay, were you saying the end pin?
I don't know if Anna, if there's an issue with that computer. But I think what she's trying to say is that, just to clarify, you can have one end pin that's synced with a specific phone. So you can't have like multiple.
Oh, I'm sorry, I can hear you.
No,
now.
you can have multiple pins synced to the app.
Oh,
Yes.
Okay.
you might need help maneuvering that one.
Yeah, and honestly, I need to go back and review that. But let me just clarify. Let me verify. It does say multiple pins can be paired to the NPIN app.
Okay, well,
Yeah. So, but anyway, we can cross that bridge together.
I had maybe two more questions. Sorry.
Okay.
If they, I guess don't have it synced, don't have their phone at school or something like that, and they just give an injection at school, would it then sync once they get home with that injection?
It should, yes.
Okay. And then I know for the Dexcom, you said there's kind of like a 3-hour delay. Would that then, I know it syncs to the calculator. Would you have to just input that for Dexcom?
That's a great question. I'm going to have to look into that. I don't know if it's something that you have to enter into the Dexcom, but well, so, and again, the way that they're interacting is by just showing is just combining the NPIN app information along with the Dexcom sensor glucose data. So as long as you're entering in the information into the NPIN app, the sensor glucose data is going to sync with it eventually on the back end.
Okay, thank you so much.
Yeah. Any other questions?
And Kristen, did you talk about, I had to step out, but did you talk about the in-light sensor and that the sensor is not the Dexcom or the Freestyle Libre, that you guys have your own sensor?
Oh, no, I did not mention that. So we have what is called Guardian Sensor 3. That is, I know that confusing because we've got Dexcom G5 and G6, but yes, Medtronic has its own sensor technology. Dexcom has its own sensor technology, as well as Libre. So they are all three different. They don't all use the same sensor.
Thank you.
Yep.
All righty.
If y'all are good to go, I will leave you guys to it. And Erica, if there's anything else y'all need from me, please just reach out and let me know, okay?
Absolutely, absolutely. We will share your information, and Medtronic is putting out new technology all the time, and so we might get an update at some point that we can pass along as well.
Yes.
So
All
thanks,
right.
Kristen.
Thanks again for having me. Bye, y'all.
All righty. All right, guys, so we are going to welcome Miss Stacy Haynes with GVOC. So I'm gonna go ahead and start our video here. There we go.
Hey, good morning. I'm so happy to be with you guys. My name is Stacy Haynes, like Erica said. I'm with Xeris Pharmaceuticals, and we have the GVOC HypoPen, which I'm super excited to share with y'all. I had the privilege of recently working the National School Nurse Association Conference in Atlanta. So maybe saw a couple of you there possibly, but it was really exciting to see how excited the school nurses were to hear about the advances that have been made and ready to use glucagon. So if we were in person, I like to ask this question when I teach in services, but how many of you have ever actually had to put together an old school 10-step glucagon emergency kit, right? As you know, what that looks like is it is a vial of liquid powder. They have to be mixed together and drawn up with a needle. Meanwhile, you have a student on the floor who is either unconscious, seizing, or going very low, and panic has set in for anyone. So we like to call it basically the EpiPen for diabetes. For the first time, glucagon is now in a pen that is ready to use. It's pre-filled, it's pre-measured, it's room temperature stable for 2 years, and you literally pull red, push yellow, and count to 5. And you can hear the auto injector release after that 5 minutes. There's also a window that's color coded that you can see the line change to red as well. It's indicated in students and patients over 2. So from 2 to 12, there's a dose of 0.5. That's 2 to 12 and under 100 pounds. And then over 12 and over 100 pounds is a 1 milligram dose. Again, that's something you'll never have to dial up. Whatever the provider, the student's doctor has written for them will be in their pen. So we're doing a lot of education right now with school nurses to make sure that you are able to train your staff. I know from working that conference, I was told that a lot of times there's not a school nurse present in every single facility, or a lot of times in lower grades where teachers spend the entire day with a particular age group and they know that they have a diabetic patient possibly in that group, that the teacher can also easily be trained in something that's just not overwhelming. So again, it's a subcutaneous injection, not intramuscular like old glucagon. So it's super easy. You would inject in all of the same spots that you would typically inject insulin. So arms, thighs, abdomen. It is recommended that it is on skin and not to be done through any type of a material. So definitely lift up their thing and go bare skin. Within 2 minutes, it starts to raise blood sugars. And the beauty of it is that in about 14 to 15 minutes, the blood sugars are back in normal range. So this does not take away from the fact that when a blood sugar begins to go low, we still want to teach carb counting. So we want to teach them to eat their 15 grams of carb and wait 15 minutes and try to watch those blood sugars begin to rise. However, we also know that sometimes the patient or student is at a situation where they're already nauseated, they're refusing to eat. You see double arrows down on that pump and you can't get them to eat anything. It's okay. You can go ahead and inject them. You do not have to wait for them to be unconscious or seizing. So it's super easy. Again, like I said, the prescription is normally written by their providers to be a 2-pen pack. So we're teaching, always keep one with you in your backpack, wherever, and then have one at home. Also, a lot of nurses like to have them in their emergency kits as well. So I know that's dependent on each school district. Additionally, we have these trainer pens that are available to you if you're conducting in-services with your own groups. And we can bring these as resources for you to use as training so that your nurses can see it, touch it, just to kind of, like I said, get a feel for how easy it really is. We're so happy to provide those or come help with any type of in-service or skill check, but it's really no different. If you have a student with a peanut allergy, you would insist that they have an EpiPen, and even though you want them to avoid peanuts at all costs. And so this is really the same thing.
When you have an EpiPen, you hope you never have to use it. And with Gvoke, it's a rescue. And we hope you never have to use this as well. But in the event of a severe hypoglycemic event, it can truly be the difference between life and death or waiting on a paramedic to arrive in that situation. So again, it's super easy. We're super excited about how easy it is, especially for school nurses and people who, you know, want and need to be able in a hurry to help a child that's, you know, in a desperate situation. So again, it's super easy. There's not a lot to it. It's room temperature stable. And I think that's pretty much it. We've spent a lot of time, like I said, trying to educate school nurses. So if your particular group would like any additional resources, we can also send you information. If you have a student come to your school and they bring in an old glucagon emergency kit and you're like, hey, have you heard about this? It's possible we launched during COVID that their providers may not know about Gvoke HypoPen. So we have some resources that you can just tell the parent, you know, at the school, we would feel much more comfortable having a HypoPen versus the kit. So possibly get them to go back and ask their provider to write that prescription for them. So it's new, so hopefully you'll see it more and more. And we're happy to answer any other questions anyone may have or provide resources. So thank y'all so much for your time. Thank you for what you do every day for students. It does not go unnoticed. And we really appreciate Le Bonheur putting on this education for all of us.
Yeah, and Stacy has done an incredible job with making sure that we kind of understand the differences. And so you're going to see this product more and more because it's now covered on TennCare and a lot of other insurances. So we've said the whole time, all of this is insurance driven. The cool thing about this, and will you demo it one more time?
Absolutely. So again, it's pull red and push yellow. So you can hear probably the audible clicks maybe over the microphone. It's super easy. Again, these are just demo pens. There's nothing in them. The needle's not in there. But when you go to use it, the needle is attached. So you won't have to attach a needle. You won't dial up anything. It's literally ready to go. It will come, when you see it with the patient, it will likely be in a foil package like this. So it's a little bit different because this is for a trainer pen and theirs is more paper, but it's literally tear off the thing and then remove the pen, pull the top, count to 5. So super simple. And then of course, dispose of the pen. It's a one-time use. And
would there be a way, and I've never asked you this before, so sorry to put you on the spot, would there be a way to get like a school Gvoke pen? Like, is there any way that they could purchase it or be able to access that? How would they go about that?
Absolutely. So if anyone on the call in your school district is interested in that, I'll have my information available for Erica to send you, but you can definitely order from any of the distributors that are out there, much like you would for, you know, in high schools. I know sometimes it's Narcan, it's, you know, EpiPens and those kind of rescue devices. So this is in that same category of rescue in an emergency situation. So we're just trying to prevent, you know, trips to the ER and those kind of things, and anything we can do to save a life and to do that faster and quicker. So it's definitely available. Each school district has different rules about what they allow to be purchased or stored in kind of their emergency kit. So it really just depends on each individual school district. And Erica, I think, is going to show you guys quickly just this is an example of, well, maybe her screen went away, but if you haven't seen the traditional kit, I think she has a picture for you of what that could look like. In addition, again, I work for Zara, so I represent the Gvoke HypoPen, but this is an example of a traditional glucagon kit, the old school, where you have to put it together, mix it up. And then the bottom right is an intranasal glucagon that's distributed by Lilly that's called Baqsimi. So that would also be something that could be used in a rescue as well when carb counting is not sufficient.
Yeah, and in the beginning of the presentation, I talked about how there are links to last year's presentation. So in the skills section, the webinar 1 link that I sent out, it does go over more in depth some of these low blood glucose treatments. One cool thing about Gvoke, and it's actually a story that I recently heard, was that there's a teenager that was at some kind of basketball, no, wrong sport, football, football training camp. And anyways, his best friend knows how to use the Gvoke. So of course it was so hot that his friend went low and he was like, you don't look right. And so they couldn't even find the blood glucose meter because he didn't take that out on the field with him. But he grabbed his Gvoke and gave that to him.
Yes.
Now, I know that there are rules and there are lots of things that go on with schools, but the more people who know about a rescue medication and the accessibility of Gvoke and Baqsimi and these new products that are coming out really gives the access for more people to feel comfortable. There's not a lot you can mess up.
Exactly.
That kind of old school, the red glucagon emergency kit, you have to mix it. And I remember you sharing all of the statistics of people who mixed it incorrectly.
Yes.
And or who just gave the diluent and not the
Exactly.
actual medication. And so this really is a cool feature. So the more people who know how to use it, the better. And another thing that we talk a little bit about is that a lot of times we associate using these products as the child is unconscious on the floor, seizing something really extreme. But if a child cannot safely eat or drink and they're dropping low or are low, and maybe they are dizzy or you just don't really trust them, you can use one of these devices. It doesn't hurt them. So it's not going to mess them up or really cause a lot of issues if you're like, I think I need to get that.
Yes.
So it's better safe than sorry. So I think a lot of people are very scared of it, but in the long run, it really does.
Yes, absolutely. And I think I had mentioned that
Decrease.
before. Like
Yeah.
it is, I think in the old school, especially nurses who were trained several years ago, we were taught that unless a patient is unconscious or seizing, don't use glucagon. And to Erica's point, you cannot hurt the student by injecting them with glucagon. So if anything, they're going to have the symptoms of nausea and vomiting, which they're likely going to have from being low anyway. So it's kind of sometimes hard to tell, is it the glucagon or is it the fact that they're just suffering from a severe hypo event? But you can definitely use it. Don't be afraid of it. You really cannot mess this up. And the beauty of it is, to Erica's point, is that it just really brings the child back into a normal blood sugar range by raising it about 175 points, where in the old school days of us trying to force feed, candy and juices and those kind of things, sometimes we end up with a student who goes from a 40 to a 450 from just, we're not waiting 15 minutes and they're freaking out and we're kind of freaking out. So you keep eating and keep ingesting. And so all of a sudden you're in this hamster wheel of chasing a low, then a high, then a low. So this is just more predictable. You know that it's really going to raise them from in that severe range up to the normal glucose levels, about 175 points. So don't be afraid of it. And especially for not just school nurses, but if you have teachers or assistants or other people, anyone that you can teach that's going to be someone who's going to be have access or be exposed to a child, possibly a diabetic, in their classroom or maybe in the gym. Those, if it's a different set of teachers, it's something that everyone can feel comfortable with and confident in helping save a life. So
Thank you so much, Stacey.
thank you
Really
so much.
appreciate
I
it.
appreciate you guys having me. And again, if I can provide resources for your school, please reach out. I would love to be a part of any in-service or drop off any additional resources. So thank you.
Thanks, Stacey. We're gonna just take just a second and I'm gonna, that concludes all of our industry partners. We're really grateful for all of them for coming. And I'm gonna come and present now. We're gonna kind of conclude everything and kind of put a few pieces together as well. So thanks,
Awesome.
Stacey.
Thank you.
Hang tight just a second and I will be right back. Alrighty, guys, so I assume that everyone's quite tired at this point. We've heard a lot of different information and there's a lot of different pieces of technology to kind of take in. So how do you take everything that you've learned today and really focus it in on a kiddo? So I don't know if we have any new school nurses, but I'll start by saying that every child that comes to Bonheur will get a school care plan. We started back at the end of April with our 2022-2023 versions of our school care plan going out. Those versions were reviewed by some of our school leader partners, and that was in the form of a diabetes advisory council. So we have people from the community, families, and school leaders who are all part of that. So if that is something that you're interested in being a part of, we meet quarterly and we go over topics. And that's really how actually this topic came about, is that our school nurse leaders were like, we want to learn more about technology. Can you make that available? So that's really why we're in this topic today. And so I'm going to kind of go over a few things. Again, I don't want you to be too overwhelmed if this is your kind of first exposure to diabetes, to our school care plans. That's just something you'll need to ask. If a patient hits Bonheur, even as a new onset in the hospital or over here in the outpatient center, they will have a school care plan. And so if for some reason they say that they don't, or they don't bring it, I'm going to show you our phone numbers in just a little bit so you can contact us and we can help you through that. So our objectives today, we're going to discuss continuous glucose monitor orders and all of our Bonheur school care plans. Can you just drag that over to the side? So, perfect. And then we're going to just kind of discuss, have kind of a candid conversation about, okay, all of these things that we've learned about today, how do we really implement that into our school environment? And then we'll have questions at the end. If we do not get to your question, or if you've got a question that you don't want to put on here, you can always email me and we'll email those answers out, just because I'm sure everyone would kind of want to know. So in our school care plans, we have continuous glucose monitor orders. So CGM stands for continuous glucose monitoring, CGM for short. And we put this in every single child's school care plan. So a child on new onset diagnosis most likely is going to come to you with a blood glucose meter and then vial and syringe insulin. They may not have a continuous glucose monitor right away. Our Medicaid patients do have to wait a little bit longer, but you may see someone with commercial insurance that does come a little bit sooner with the CGM. And so our orders will stand with every single school care plan. So you'll notice that within this, it has different values that are set. These are the settings for alarms that we recommend. So the blood glucose setting of 70, and then for low, and then 250. Anna, remind me, what is the hard stop on a Dexcom, like that it is going to automatically alert?
How high it gets?
No, the low, the urgent low soon. It's you, Sonic. 55. So 55, you can't turn that alarm off. That's the urgent low soon, but the rest of them you can program. Now, we have recommendations. However, our parents can be quite anxious at times, especially anxious in the beginning. And so they may have kind of peculiar settings. So they may have their low alarm set at 110 just because they want to, it happens. And so you're not going to respond to that alarm. You're responding based on the school care plan, based on that rule of 15 and all of those components. And you can go back in our presentations and see last year's presentation about that, but it'll also be in that school care plan order. The same goes for 250. A parent may be very anxious and they want to know if their child is high at 180 and they have an alarm set at 180. So if these alarms are going off every 5 minutes in the child's classroom, that probably needs to be a conversation. Hey, like Bonheur's orders say this, is there any way that we can modify those alarms while the child's at school so that we really can have them participating in class? Because the blood sugars will fluctuate. A kid is not going to be perfectly between 70 and 150, even though that's our target goal. They're going to fluctuate through the day. So we want to make sure that those alarms are set in a manner that really can produce the best results, because they may go over 250 right after they eat, which makes sense. They just ate. So we're not going to panic over that. The biggest thing I think that's evolved over the years is allow students to have access to the CGM receiver or phone at all times, as well as you'll see Wi-Fi access. This is something that is standard across the board. And as you saw these different products presented, more and more of them are utilizing the child's phone. I can't even imagine how tricky that must be for you guys to really figure out how to work that into a classroom setting, because I assume from what I've heard from school nurses is that phones aren't allowed for other students. So finding a way to work around that, we're going to talk a little bit about that in a minute, but this is kind of our standard orders. Like we said before, and Anna mentioned, a kid's going to go back and forth. They may have a Dexcom one day, they may have a freestyle the next week, they may have monitoring supplies with finger sticks the next. And that is becoming more and more common because insurance is cracking down on how much they'll give, and they're denying things, just a lot of different things. One thing that neither of the reps said is that if they've got a sensor that fails or a site that fails, or if any of the stuff does not last as many days as it's supposed to, so let's say a Dexcom sensor does not last the whole 10 days, that family can actually call the company to get more. So I know you guys facilitate a lot of different questions like that, but that is one thing that goes into this. At the very start of the orders, you'll see what the parent is responsible for in the realm of supplies. And so you'll need to talk with the parent about really what the course of action is going to be. There may be some things that need to go back and forth. We talked about the N pen. One N pen, I think that patients could potentially get for $35, but a second one could be hundreds of dollars, right, Anna? So, I mean, they may truly have one N pen they can take back and forth. So your stock is going to need to reflect that. I know in previous years, maybe about 5 years ago, families could have a complete stock at home and a complete stock at school, but that's just not the case anymore based on insurance coverage. So some stuff is going to have to go back and forth. And then just the other things, the parents are responsible for these things. So we get calls all the time that, oh, they didn't bring their insulin. Well, I don't know what to tell you. They can't safely be at school without these things. So this is something on the front end to really have great conversations about, okay, like who's going to be responsible for what and who's touching base, and your child cannot safely attend school without these things. And so the other thing is they're going to need to make sure that they come to regular appointments. We see our diabetes patients at least every 3 months. And in the beginning, they have a whole education series, which you can go back on last year's video on the second webinar and watch all about that, new onset all the way through their diagnosis. We talk about that. But if they don't come, we had a parent the other day that called and they haven't been here in like 13 months. We can't safely send refills or even send a school care plan until we see them. It's just not safe. So if we haven't seen them at least in 6 months, they may not get refills. So that's one of those things too that we just want to make sure that we're all helping them out. And so we really appreciate you guys. I know one of our school nurses, Miss Cindy Hogg, called us yesterday and was like, oh, I got to really help this one new onset patient out that was just diagnosed 2 weeks ago, and she was a rock star with that. So, you know, we're here to help to try to figure these things out. One other thing you're going to see in these orders that looks a little different is under the insulin dosing section. So under this section, it'll say what insulin pump a child is using. I think we're going to find more and more that patients are utilizing different pieces of technology. That has not been the case in the past, but I think it's going to be more and more common. We've got a bunch of patients who recently went on Tandem, but they may choose to utilize the Omnipod 5 as it rolls out because they're kind of different coverages. You've got one that goes through medical benefits and one that goes through pharmacy benefits. So you might see children with different pumps, and each of those pumps are going to have settings in them. So we talked a little bit about basal rates. So basal insulin gives a little bit of insulin in the background all the time. And so for a pump, the cool thing about it is we get to manipulate how much insulin it's giving over time. So for those standard pumps, and the ones that are on the market right now that you would probably see this with are the Omnipod Eros and the Omnipod Dash that have set doses, and they give those amount of doses over time. So a kid might get 0.5 units of Novolog an hour or 0.1 units of Novolog an hour, but they go higher after breakfast. So at 10 o'clock in the morning, they may get a little bit more. The thing is, you don't have to worry about this. The parent is responsible for making sure that all of this is correctly in the pump. You shouldn't be manipulating this unless you're wanting to help them out somehow. Now, for our pumps that automatically use an algorithm, we have this. So we've got our, this is pretty much the same. You've got your units of insulin for every grams of carbs, and then you've got your correction dose, right? That typically looks like all of our school care plans where our kids are doing insulin to carbon correction dosing. Again, if you are a new school nurse, do not panic. This looks crazy. Go back and watch our other webinars. There's a whole section about insulin dosing, insulin to carb ratio. We've got a section where our dietitian talks, as well as one of our nurses explains dose calculations. So don't panic, go there. Get that great resource. But you'll notice this little line at the end of this that says provide nutrition and correction bolus per pump calculator by entering carbs and blood sugar and pump. Okay, so the pump reps were talking a little bit about how they pulled up their dose calculator and it synced with the continuous glucose monitor, so our CGMs, or for the Medtronic, the Enlight sensor, and it's going to suggest a dose. That suggested dose is based off of the algorithm that's working in those smart pumps. So for that, we have our Medtronic 670G, we have our Tandem Control IQ pump, and then we also have the Omnipod 5 system. Each of those systems has a different algorithm, which means they take the continuous glucose monitor reading and the arrows that go into that. And then they also take all the insulin that's been administered, both in the basal rates that we just talked about, as well as the bolus. If you just gave insulin for 2 pieces of pizza and then you go right back behind that to try to give more insulin, it's also going to be able to see what all is going on. And that calculation might be different than if you were to do all these calculations by hand. The reason why is because it's working in the background to figure out exactly how much insulin is needed for that scenario, which is pretty cool. And we've seen really great results with that. I know that for me, I'm someone who doesn't always trust a system. I'm like, is it working well? But it is really showing phenomenal results. We see the issues when parents and patients go in to kind of manipulate things themselves and they don't trust the pump. So with this, you'll see this disclaimer, provide nutrition and correction dose per pump calculator. So yes, whatever that pump tells you, that's what you can double check it, make sure you have carbs right, make sure that blood sugar looks right. If the blood sugar doesn't match the patient presentation, then yeah, you might want to kind of investigate that a little bit further. But otherwise, we're going to give that correction dose based on that. Snacks as well. The snack section looks very similar to the snack sections in the other school care plans. The insulin to carbon correction factor, or MDI, which I don't know if you caught that earlier, but that just means multiple daily injections. And so with this, you'll see there's a little disclaimer that says provide snack bolus per pump calculator by entering carbs in pump. We're not at this point doing a correction dose. So we're not using the blood sugar feature. So as they kind of showed you before, you're just entering for the carbs that the child is eating. This will go for like a pizza party in the afternoon or something else. We want kids to be able to participate. So when you're looking at those orders, this is where you're going to look. With this as well, you are entering or you are administering the amount of insulin that pump calculator tells you to do. The same actually goes for the NPen as well. The NPen is a little bit different and it has its own built-in calculator, which is really, really cool. And it also takes into account insulin on board, which is just a little bit different. It's fine. As long as they're consistently doing the same thing, then we can make changes off of that. So we don't want to override any of these calculators. That's what we want to administer. And their rounding might be a little bit different, but whatever the patient is consistently doing, that's what we're going to go with. So let's go to the next slide. One other thing is with high blood sugars, you're going to see that it looks just a little different. So in one of these sections, it's going to say provide sugar-free fluids over the next hour, and then we're going to recheck the blood sugar. And if you look at number 1, it says at the 1 hour recheck, if blood sugar has not gone down by at least 50 points, Then we're going to administer insulin by injection according to the blood sugar correction dose found under the insulin regimen section of the school care plan. That is something that you guys are going to need to talk through with the family, because you're going to need access to insulin in a vial or a pen or however they have it, as well as syringes. So you're going to need those supplies also at school, even if a patient is on a pump. We always want to kind of think about worst case scenario when it comes to all of our supplies. Technology will fail at some point. It's not perfect. So we want to have that backup plan in place. With this as well, it says the pump infusion site will need to be changed and pump function assessed. I think that the presenters, both Tamala and Omnipod in the beginning, Miss Leah did a great job about talking about when you're really assessing that pump site. If it's super red, if you smell insulin, the patient is complaining about it, or the blood sugars just got high and we're like, what is going on? Those are things that we're kind of assessing. And so when it comes to pump site changes, we'll talk about that in just a minute. And then at the 1 hour recheck, if blood sugar has not gone down by at least 50 points, and continue to provide sugar-free fluids over the next hour. You're going to want to follow these sick day rules, or I'm sorry, hyperglycemia section within the school care plan. In a minute at the end, I'm going to give you our phone numbers. So if you are very anxious when you're having to do this, and you're like, hey, I just need a little bit of help, I need to walk through this with someone, because you may only do it once while the child is under your care, then call us. That's what we're here for. So we've got some phone numbers you can call for assistance in troubleshooting this. So now I'm going to go into just a few frequently asked questions when it comes to our technology. We have, like I said, an emergency line that our phone nurse answers, and my office happens to be back there with them. So I hear a lot of these different things. Just so that you know as well, we have had a big push over the last couple of months within our own individual clinic of really understanding and wrapping our heads around technology to be able to better equip others and respond if someone's got a question, whether that's a family member or whether that is a school nurse or something of that nature. So we really have beefed up our baseline understanding and ability to assist within different environments. So let's get into it. So what will be the plan if a pump site needs to be changed? So I've got just a few things that I suggest you guys, as these parents come in and request their 504 plans, we push them, especially if they're in the public school system. We need you to go to the school, give them a school care plan, request a 504 plan. I know that that's parent and patient driven, but I think that that is really the place to handle and discuss a lot of these little bitty things that go into implementing technology within your specific school, because an elementary school is different than a high school, and one school system may have more resources than another and things of that nature. So pump site changes. Can the patient change it themselves? Are they responsible enough? We as Bonheur are not dictating if they are responsible enough. That's just a conversation between the school and the parent. Would the parent need to come to the school to complete? That's perfectly doable. Is there someone that is willing to be taught by the family or a trainer? Or is there an older child, like a sibling within the school, who typically helps with site changes or something of that nature? Who would be there? If nobody within the school is comfortable with that, then that goes back to the parent. Then the parent would either need to come and change that site, or get someone to come up there within their family or friends, or they would need to come and pick up the child and take them home from school. Whatever, you guys want to put into place. They're typical pump changes. So depending on the child, they should be changing their pump site every 2 to 3 days, kind of depending on how long it lasts for them. They should be doing that at home. That should not be the responsibility of the school nurse. Where we're talking about pump site changes, it's more of if there's an issue. If they have a site that's somewhat infiltrated or is not working appropriately, or they're having some kind of reaction, then those are really the circumstances that we're talking about here. So that's just a conversation that you guys can have and choose as you wish for each individual child. Another question you want to ask is, who is responsible for entering the values into the pump? Is the child responsible for that? Is the nurse responsible for that? Is someone else appointed to that? Can it be their teacher who's just looking at it and be trained and cross-trained? you know, whatever it takes to kind of keep the kid in their normal setting as best as possible. The more people we can kind of involve in the process, the better experience for the child. But who will oversee that? If it's a small child, it definitely needs to be done by someone else. But if it's a teenager, hey, they're super responsible, they're doing what they're supposed to be doing. The family's like, yeah. I know I've talked to Collierville schools, and they've got kids who just do their own thing and do a phenomenal job, and they've got insulin pumps. So those are just conversations that you guys are going to want to nail down altogether. One other thing that we get questions about a lot that's typically in a sheer panic is standardized testing. So these are parent-driven requests for accommodations with standardized testing, and I highly recommend starting the discussion and planning early. The ADA, so American Diabetes Association, has some information for resources, and I've included that link right there. The best way that I've kind of seen this done is that if you've got a school standardized test, then the parents and the teacher and whoever, they come up with a plan and they do a mock one. So if you've just got a simple math test, hey, let's act like this is a real environment. Let's kind of go through the steps to see if that works. And then that makes that experience a little less stressful for the student when they truly go into a very anxiety-ridden situation with the standardized test. When it comes to the ACT, SAT, those sorts of tests, and PSAT, I don't even really know what exists anymore. I'm feeling super old, but all of those testings, then you're going to want to make sure you're working with that individual site and what they can accommodate, and reaching out to them early to figure out what you need to do with that. There are laws that go into this as well that the ADA has there on that website. Other discussion points is the responsibility of the parent to notify the school of any dose changes. Just so that you know, every time that Bonheur changes doses for a child, we give them a new school care plan. Patients also have access to like an online forum, which is called our patient portal. So if we make changes, even if they call us and tell us that they're having issues and we make changes to their doses, we can create a new school care plan and send that over to them. They can actually save it and email it to you or whatever. Very, very, very functional. So we love that patient portal access. You know, if a parent is saying, hey, like we made these changes and this is what we did, but we didn't consult with the Bonheur, then we're going to need to really have a conversation with that family before we can send a new school care plan. This is going to go more in the realm of those patients who are on multiple daily injections, who are doing those calculations, or if they've got a different sliding scale. For the most part, the pump kind of does its own thing. So it's really going to be their responsibility to make sure those settings are correct. This is a big one. Okay, so these suggested discussion points: clarify expectations of smartphones. So iPhone, Android, whatever device the patient is using, by the end of this year, most of these pumps are all going to be using a smartphone. So they need access to that medically. But it's up to you guys as how you want to maneuver that, because I know there's a lot of behavioral concerns that come with smartphones. So some suggestions from, you know, your peers, or does the child need to keep the phone in a specific place on their desk? I know one school, they decided, okay, they can keep the phone on their desk, but it must be in the top right-hand corner. And when they started that child out with that parameter, they actually taped a little box on that child's desk. I think that this was still an elementary school age child, but it became a habit that, okay, you put it in the box and you only respond and look at it when there's a mobile alarm. So that was really the way that they did that. And the only app that they could have up was that, I think it was the Dexcom app. Do teachers need to keep the phone on their desk, and are they responsible for looking at it? That's a little bit more responsibility. So, but that is an option if your children or your students can't have any devices. Something else that you guys need to discuss is Wi-Fi available, because a lot of these devices are going to need Wi-Fi access. Is it possible for them to turn off cellular access and still have access to their apps with Tandem and Omnipod and Dexcom? A good question, right? Also, like, what are the parent expectations for technology? Sometimes I think we all are kind of spinning in our own realms and we kind of all have different expectations. And so ask them what the expectations are and then try to find a way to kind of meet them halfway. You don't have to meet every single demand. A lot of times we'll get requests from either parents or schools. They want this whole laundry list of things. We're not mandating any of that. And so it's agreed upon with the school what's doable, because what's doable in one school system with one set of personnel might not be the same for a smaller school or a high school setting. I know one of the DeSoto County nurses told me she's got, I can't even remember, like 10 or 15 high schoolers with diabetes. Well, you know, that's a whole different realm than just having one kid. So just responsibilities and expectations. It's also good to know like what the alarm settings are. So did they set those CGM settings to beep at 115 for a low and 180 for a high? Well, that thing's going to be going off all the time. So could we change that for school? It's also kind of good to know what those sounds are so it doesn't panic anybody, because they're kind of scary when you hear those alerts. I have coworkers, so we all kind of turn around and it really does distract you when those alarms go off, and it can really interrupt a school environment, especially in a classroom. So knowing what those sound like and really helping the teachers and students as well, kind of training everybody. Okay, well, we're not gonna like panic. We're gonna let JT do his own thing, you know. So, and then who will need to respond? Is the child responsible for responding? Does the teacher kind of give them a hey sign? I know one of our 504 recommendations is to have like little color signs for teachers. Might be a little corny, I don't know, but a blue sign means I need water. A red sign means I need to go see the nurse, or I don't feel good, I need to check my blood sugar, I need help. You know, just like little things, especially for students who don't want to draw attention to themselves. I know another like high schooler, he's super charismatic, but he just like has like numbers and just like does little dances. And so like let his teacher know. So the teacher still needs to know what's going on. So all of those kinds of things need to be discussed. This is my favorite, ironically. So what expectations should the patient be aware of for behavioral concerns? Let me tell you, probably half of the calls that we get from schools are about this. Okay, so we've got all of these modifications we're making. Can you check the chat and just see if it says something on there? We've made all these accommodations. Okay, yeah. Before, what happens when the kid acts out, right? Because kids are kids. So one of the examples is a child with diabetes is using a cell phone to make TikTok videos. Okay, kind of having these conversations with schools early, and you can blame us. Hey, Bonheur like gave these examples, so we need to kind of figure out what the behavioral plan would be if the child abuses their phone privileges. They still need access to that data and to their devices, but where do we go with this? And they still should have disciplinary action, or could, I don't know. I did have a stint in school nursing, but I still want to be respectful of that, whatever you guys decide behaviorally. But it can be separate from the diabetes. Yes, it's because of accommodations that they have, but we see kids abuse those all the time, but they still need access to the resources. Another example, a child states they need a bathroom break. This is in elementary school. These are real examples, by the way. Child states they need a bathroom break, but the child wanders off to the playground instead. What happens then? So I know for this specific child, they the teachers had bathroom breaks, I think, every hour. And I don't know what it's like in other school settings, but that fixed the problem. So they had bathroom breaks for this child every hour, and the whole class would go. I know that that's a lot to ask, but that fixed that problem. Another example, a child pours their whole water bottle on a classmate. What would that, they still need access to water, but what would that disciplinary action be for that action? And then how do we address water, still having access to that? They do need unlimited access to water in the restroom. And so that'll kind of be a something that you guys will have to talk about. Another one that I heard earlier was, you know, those crunchy water bottles. the kid just like crunched it all the time. And I'm like, how about we go with the metal water bottle? And they're like, oh, that's a great idea. So it's like sometimes when you're in the thick of it, you can't really see, but those are definitely things that we want to address. Can you click back on it? All right, one really cool resource that we found is the American Diabetes Association put out new guidelines and standardizations for usage of continuous glucose monitors, and especially continuous glucose monitors in the school setting. So what I'll do is I'll send this document out to you so that you'll have it. It's a couple pages, and it just kind of really, I think, gives a better understanding of what CGMs are and what really should be accommodated within the school, if at all possible. And so anyways, I'll send that out to you guys. I'm not going to harp on that too long. Our contact information. So some of our contact information, if you've got that blood glucose concern, you've got those ketones, you're struggling to kind of figure out what to do next as far as especially a blood sugar, or even if you've got a kid in front of you and you're like, oh, you were diagnosed with diabetes, but you don't have anything for me. And okay, that's the number you're going to call, 287-6659, 901-287-6659. You're going to be triaged to one of the diabetes emergency line nurses. You'll need to know the patient's name and their date of birth, and as well as that you're trying to call the diabetes clinic. If you are just kind of wondering about something, you just kind of got a general concern or something you want to talk through, typically at the beginning of the year, we have nurses who are like, hey, I just want to talk through this with somebody. Absolutely. Call 901-287-7337. You'll be put into the phone triage thing. They'll ask for a message, and one of the clinic nurses or educators will give you a call back. Something new that we've added, and this was requested by some of our nurse partners within our advisory council, as a contact if a supervisor needs help. So if you are a nursing supervisor and you are needing assistance, you need someone to talk to, my name's Erica, I'm the diabetes education coordinator, and that's my desk phone, 901-287-6841. Give me a call. I'm not always at my desk, I'm all the way around. So if you need help urgently, you need to call one of these other numbers. But if you're like, hey, I need to, this is bigger, I really need to talk to someone directly to help coordinate something, then you're gonna call me and I'm gonna help you. My email address has been on all of the resources as well. It's erica.davis@lebonheur.org. Just please don't email me patient concerns. Just with our system, it's either going to flag it and it won't come to me, or it's just going to kind of be a HIPAA issue. So if you've got an issue, you can kind of email it over to me, but or hey, can you call me at some point, those kinds of things. Then that is there. And then we've got our company contacts. What I'm going to do for you guys, as well as I'm going to send you out this PowerPoint in the final message, but you've got Tamala's information. You met her with Omnipod, the actual educator. Her name is Leslie Draff, and there's at a convention today. That's why Miss Leah presented for us. There's Miss Kristen's information with Medtronic. We've got two people for Dexcom. Miss Meg is our educator. Miss Kat is our industry partner. And Freestyle Libre, Miss Damaris's information is on there, and then Stacy with G-Book. So if you've got any direct questions for any of these ladies, then you can reach out to them. And then I was just going to see if anybody's got any questions. One of our educators did bring up that our school excuse policy has changed. And that was sent out with every patient starting in April when they came to their appointments. But I worked with some of you guys, again, some of our nurse leaders, to figure out what your school excuse policies are. But we really, our goal is to have every child in school as much as possible. The only reason that they should be missing school is if they've got ketones that won't clear. So they've got moderate to large ketones that don't go away. Look in your hyperglycemia section of the child school care plan, it'll kind of walk you through that. If they're having persistent ketones day after day, there's something wrong. They're either not getting their insulin appropriately, or maybe the insulin has been damaged or something of that nature, but they should not have sustained ketones unless they're sick. There's some other reasons, but if that's an issue, they need to contact us. for that. But the goal is to have them in school as much as possible. So we are tracking those school excuses, and we've kind of cracked down on that policy. So, you know, just so that you guys know, if they come for an appointment, they come for a class, they come for labs, they come for anything on Le Bonheur property, we will give them a school excuse. Or they can request a school excuse. Sorry, I'm looking at our scheduler. If they have an encounter with us, then that's something that we can assist with. But anything else, if they've got some kind of stomach bug and they've been sick, that they need to request from their primary care doctor. So we really do want to include that primary care doctor as well. Does anybody have any questions? You come out of this, so let me just go back out. If not, I've got a few other things that we can, yeah, just stop the share. All right. I don't see any questions, so a few things that we can talk about. Not sure. I know Catherine's on here. I don't really know what she's talking about on some of these. Parents should guide specific. So the orders that you're going to get, we've got something funny to tell you in a second. The orders that you're going to get are medical orders. So those are the mandatory orders that have to be carried out no matter who is on the premises. So if every nurse you has COVID and is out, then those are the basic orders that have to be carried out for that patient. All the little specifics that you heard today, it's really hard to articulate that in a manner that can be in order format. It's getting a little bit excessive at times with what patients and parents ask for, and we're not mandating that all of the things that they're asking for will happen at school. And so that's really going to have to be a conversation between you guys of what's doable and what's not doable, and maybe what's doable with certain personnel. So yeah, if you've got your school nurse there that's always there, then this is the road that we're going to head down. But if for some reason they're not there and this backup person is handling it, okay, then we're reverting to plan B. It doesn't have to always be the same exact, you know, course of action, because we know that people are going to be out from time to time. So, Anna, do you want to tell a story about the infant?
You want
you can just.
So it's Anna again. So I just reviewing the InPen. That was that smart pen that y'all saw that was covered with Medtronic. So it's a smart pen. It can come in like blue, silver, or pink. And so it's a newer device, so I don't think schools were as familiar, but one kid who had the InPen, I think, got in trouble because they thought it was a vape. And so I think he was kind of a troubled kid to begin with. So it was just something that didn't seem out of the ordinary for this kid particularly. But I know y'all did see what it looked like. So maybe anyway, just kind of becoming familiar with these different types of technology. I don't think it was the school nurse. I think it was somebody else that saw it and kind of brought it to some administrator's attention. But it has happened that they've thought these devices are different things. So it is good to become aware of kind of all the technology that is out there.
And it's good too, as you're making the 504 plan, their course of treatment will change. And so if something does change, if they're on a new piece of technology, kind of saying, hey, let us know what's going on, like keep in contact and figure out a way of how you guys want to contact. We have one family that they text with their school nurse. If I were a school nurse, I would not want someone texting me all day long. Someone else uses email. And so another person just uses like paper in their agenda, like they have an agenda and then they write little notes every day. So anyways, however you guys want to form a communication, but communication is key for figuring out, well, you dropped down, I think someone just had a message. For figuring out what you're going to do and how you're going to move forward. I think that's all. One other thing that I think Anna brought up as well is sometimes I think that there's an understanding that there's a hierarchy. So the kids who have the best control of their diabetes or doing the best are on pumps and CGMs. That is not the case. With these new pieces of technology and all the benefits that they have to offer, there's a huge push to put more and more children on CGMs, on Dexcom, on Freestyle Libre, and on pumps as well with these closed loop systems. We even have a QI project going on right now with some of our high risk kids. And so it's not an automatic assumption that, oh, they have this technology, they've done a phenomenal job and they're going to be able to do it on their own. That is not the case. You're going to need to be more and more involved with these children as you see them, and there are going to be more and more patients on technology. They don't have to have technology though. So, you know, we have athletes and other students who just don't want it, and they do a phenomenal job managing their diabetes with finger sticks and then insulin vial and syringe or insulin pens. So, you know, they really have that freedom. They have that choice. They could even choose to have a pump break. Sometimes our kids, especially in the summer months, come in and they're on their injections because it's just easier in the summertime for them with swimming or activities or things of that nature. But then they want to go back on the pump a little bit later. We totally support that. We want them to have ownership over really what works for them, to try to decrease that stress, anxiety, and diabetes distress. So those are just kind of a few things. Anything else you can think of, Anna? Catherine, anything else you can think of?
I knew you were gonna make me talk in a minute. Y'all have to excuse me because I kind of like stories. I think Erica did a fantastic job of talking about the 504 plans, and especially talking about Wi-Fi and Dexcoms. I know I've taken a number of calls about those. And one of the suggestions or one of the reminders is that, I mean, I know in my day, if you had a beeper or a cell phone, automatically expelled from school, the end. So I'm never sure how people actually handle that now, but especially standardized testing, I know that's a huge concern for people, and we get a lot of calls sort of at the last minute from parents freaking out. So something just to remember, I know it was presented already, but with the Dexcom, the reader, or if they're using the cell phone as the reader, either way, it does need to be within 20 feet of the student without something blocking the way, like a desk or something else like that. So it absolutely can go on somebody's desk to watch it instead of on the kiddo's desk, so you're sure they're not using a calculator or whatever it is. But just as a reminder, it can be somewhere else. It just needs to be within 20 feet.
And what you bring up a good point too, Catherine. So even these apps have the ability to share the data. One of the DeSoto County nurses was telling me, she's like, there's no way that I can even have access to that many patients to watch their CGMs. And it's so true. So you guys are going to have to figure out what works for you, and you set those boundaries. If you're like, no, I can't share it, but let's find a way to figure it out. I know we had a kid in Jackson, Madison County schools, and I think that they were sharing with their friend. So their friend had the Dexcom data too and was able to help, and they formulated that plan specifically for that patient. And that friend was really that backup. Again, that was in a high school setting with really responsible kids. So you've got your variety of kids that you're talking about. So these 504 plans and really how you address diabetes technology is going to have to be very specialized to the trust that you have with that child, as well as really what's going on with them in general. Yep. All right. Well, if no one has any other questions that they want to talk about, then we'll go ahead and end this presentation. We're really grateful for your time and your attendance. If you have any questions that you didn't want to say on here, you think about later, I know some of you guys are all together in a group. You can definitely email me. That's Erica, erica.davis@lebonheur.org. And we'll send out some more resources. If there's some specific questions you have about the specific products that were talked about, then I'll send this PowerPoint out too, so that you can have everyone's contact information. Everyone is really excited to hear from you guys if you need any additional training. Or if you'd like to bring one of these reps back, if you're like, dude, all this went over my head, it's way too much, that's okay. Like, you can ask these ladies that presented today in the companies if you would like a different in-service, a more in-depth in-service. They are very gracious to try to figure out a way to help you guys out. So you can definitely ask for that as well. So it's a pleasure seeing you guys, and we will see you next year.